Welcome all members to the 17th annual conference of the Association of Oncologists of Northeast India. This is a very difficult situation, and last year also we could not come together for a physical meeting, and this time, in spite of a lot of effort from Dr. Arup Rai Burman at Agartala, finally we had to shift it out from Agartala and then put it everything into a virtual mode. Still, we go on. We have to go on. The fight has to go on. Fight against COVID, fight against cancer. Can you hear me?
Yes, sir.
Yes, sir.
Yeah. We are clear.
So we are here. I have seen till now 31 people have joined. So the enthusiasm is very high. I'm very happy to see that all the youngsters have joined already, who are going to present their posters as well as their videos here. The judges are also here. Partho will be joining very soon. He's very enthusiastic. I'm very happy to see the face of Dr. Tomcha Singh after a very long time. Of course, I am very happy to see all of you here together. So let us go ahead. Because you start these proceedings and we go to the business.
Yes, sir. Thank you, sir.
Thank you.
And on behalf of AONEI, I welcome all of you for the 17th annual conference of AONEI. My seniors, Dr. Bhuyan, who is the president of AONEI, one of our founder members also, Dr. Tomcha Singh from Manipur, Imphal. He is always being supportive for all the sessions, conferences, and even in our AONEI committee also, he is one of our basic support. And all other AONEI members, including Dr. Saharia, Dr. Naveen, are present there, Dr. Gaurav, Dr. Jyotiman. So I welcome all of you, and I congratulate all of the doctors who had submitted their abstract for the poster. Because of the virtual meeting, we cannot have the physical poster. So this was converted as a presentation. So today we have received around 22 abstract. One of the abstract will not be able to present. So we have around 21 abstract for the today's session. We have abstract received from Guwahati, RIMS Imphal, then Assam Medical College, Bibruwa. We also have received abstract from Mansi, Delhi also. So I congratulate them on and give best of luck for the sessions. We have our judges for the sessions. Our judges are Dr. Arup Jyoti Barua. Hello, Dr. Arup.
Yeah,
Dr. Arup Jyoti Barua is the associate professor in the Department of General Surgery at NIGRIM, Shillong. Dr. Tomcha Singh is the senior radiation oncologist, one of the founder of AONEI and Northeast AONEI also. He is the professor of radiation oncology, RIMS Imphal, ex-professor, and now he is a senior consultant radiation oncologist at American Oncology Institute, Imphal. Dr. Ramesh Saharia is our esteemed member of AONEI. He is a consultant surgical oncologist at Dibrugarh, Assam. Hello, Dr. Ramesh. Dr. Sharon Lingdo is our consultant radiation oncologist. She has done her MD from CMC Vellore. Now she is working as a consultant radiation oncologist at Bethany Hospital, Shillong. And Dr. P.S. Roy, Partho Sarthi Roy, who is the DM Medical Oncology. Currently, he is working as a professor in Medical Oncology Department at Bibruwa Cancer Institute, Guwahati. So I welcome all of the judges. We are already forwarded the evaluation sheet to all of you. We request that you give the marks accordingly, and the same could be you can scan it or WhatsApp it to me or to the email which is provided in the brochure. So without wasting much time, I hand over the session to Dr. Naveen Nayan, who is our session coordinator. Dr. Naveen Nayan is a radiation oncologist. He is assistant professor in Negrims. We go ahead with the session. Partho, you have joined. Partho Roy, P.S. Roy. I think we can start the session. I'll hand over to Naveen to start the session. I think all other judges are there.
Good evening, everyone. So, Dr. Vikas Jagtap has introduced all our esteemed judges, and just for the information, all the poster presentations will be of 7 minutes and 5 minutes presentation and 2 minutes question and answer. I request judges because the number of abstract submission is very high, approximately 22. So 2 or 3 questions shall be allowed to for each candidate. So our first candidate is Dr. Rahul Mahawar. Dr. Rahul Mahawar.
Yes, sir.
Yes. So you can proceed.
Okay, sir. Good evening to all the respected judges and members. My name is Dr. Rahul Mahawar from Department of Radiation Oncology, RIMS. I will be presenting a topic of comparative study of neoadjuvant chemoradiation followed by surgery versus surgery followed by adjuvant chemoradiation in rectal cancer stage 2 and 3. Next slide. Okay, rectal cancer is the third most common cancer in the world and it is the second most common cause of cancer death. Its incidence varies with country. It is the seventh most common cancer death in India. Most common type is adenocarcinoma and it produces minimal or no symptoms. Pre-operative neoadjuvant concurrent chemoradiation therapy is actually the standard of treatment in stage 2 and stage 3 rectal cancer. There are various advantages of pre-operative neoadjuvant concurrent radiotherapy, such as improved compliance, reduced toxicity, tumor downstaging, and improved rate after surgery, along with good quality of life. In this study, we have used tablet capecitabine in form of concurrent chemoradiation therapy. Next slide. The aim of this topic is to compare the disease-free survival between the two arms along with the toxicity profile. Next slide. Method. A randomized control trial was conducted at the Department of Radiation Oncology, RIMS, Manipur. The study population were all those who were histopathologically confirmed cases of rectal cancer, stage 2 and 3. Sample size was 50 and Cobalt 60 teletherapy machine was used. All eligible patients were divided into two arms, arm A and arm B. In arm A, patients were treated with EBRT to a total dose of 50 gray in 25 fraction, concurrently with tablet capecitabine, 2 tablets twice daily, followed by surgery 3 to 6 weeks after the completion of chemoradiation. In arm B, patients were first treated with surgery, followed by adjuvant chemoradiation 3 to 6 weeks after surgery to a total dose of 50 gray in 25 fraction along with tablet capecitabine. Next slide. Radiation treatment in both the arms received the same treatment protocol and EBRT was delivered by a Cobalt 60 machine by either 3-field or 4-field technique. A target volume in arm A, which was a preoperative arm, was primary tumor, mesorectum, internal iliac, obturator, and presacral nodes. Whereas in arm B, which was a post-operative group, it was tumor bed, anastomosis, mesorectum. Follow-up and assessment were done weekly, and all the adverse effects or untoward side effects were looked after. Treatment was deferred if hemoglobin was less than 8, TLC less than 3000, and platelet less than 1 lakh. Acute radiation and chemotherapy toxicity was evaluated on the basis of RTOG criteria. Late radiation and chemotherapy toxicity was assessed in 2 and 4 months, and response was evaluated at 6 weeks. Statistics analysis was done by SPSS Statistics version 22. Next slide. The result was a sample size of 54 was actually calculated, but because of the limited time period of 18 months only, in each arm 25 patients were calculated. Majority of the patients were less than 40 years of age, with male-female ratio being 1.17:1. KPS score, most of the patients were 80%. Stage 3 was the most common, with stage 3B being the predominant. As far as acute toxicity profile is concerned, grade 1 anemia was more common in arm B as compared to arm A during the first week of treatment, which subsequently decreased during the further follow-up. Grade 1 leukopenia was also 32% in arm A along with 36% in arm B. Grade 1 skin toxicity was comparable in both arms, with one patient in group B having grade 3 toxicity. Grade 1 mucositis was also more in group B as compared to arm A. Nausea and vomiting were the most common GI toxicity during the first week of treatment, with grade 1 GI toxicity being more common in arm B as compared to arm A. There was increased frequency and change in bowel habits in both the arms, more in arm B as compared to arm A, with one patient in arm B having grade 3 toxicity. Next slide. Late toxicity profile, skin toxicity and mucositis were comparable in both arms, with grade 1 renal toxicity being 12% in arm A and 60% in arm B. Grade 1 bladder toxicity was 12% in arm A and 20% in arm B at 2 months, which reduced in the following months. GI toxicity at 2 months were minimal in both the arms. This is a Kaplan-Meier curve showing comparing the disease-free survival both the arms. The disease-free survival was 78.6% in arm A and 75.4% in arm B, with a median survival of 20.1 months in arm A and 19.8 months in arm B. Next slide. This is a Kaplan-Meier. This is a survival curve along with the table showing that there was no significant difference in the disease-free survival between both the arms, with a p-value of 0.923. The p-value of less than 0.5 was considered as to be significant only. Next slide. This is a table showing the Cox professional hazard analysis between the co-variables for disease-free survival and adjusted Cox professional hazard ratio. Both the tables are showing no significant difference in the age, gender, and stage of the tumor on disease-free survival. Next slide. The conclusion of the topic is rectal cancer management, which has improved significantly in recent years, with improved disease-free survival, overall survival, local recurrence, and toxicity profile because of the improved surgical techniques and neoadjuvant radiotherapy. In this study, 50 patients who were diagnosed as stage 2 and stage 3 rectal cancer on the basis of histopathology were examined, and disease-free survival and toxicity profile was checked in between the two arms. Arm A was the neoadjuvant chemoradiotherapy followed by surgery, and arm B was surgery followed by adjuvant chemoradiation. In this study, 5 patients in each arm who had
Rahul, you have 1 minute left.
In each study, there were 5 patients in each arm who had a progression or recurrence of the disease, and other patients either had a stable disease-free status, dead, or defaulted during the course of the follow-up, and hence were censored in the analysis. In both the arm, 1 patient had died. Disease-free survival was 78.6% in arm A and 75.4% in arm B, with no statistically significant difference. Early toxicity and late toxicity were relatively less in the neoadjuvant arm, that is arm A, as compared to arm B. The major limitation of this study was a time constraint, due to which longer duration of follow-up should be done. Another limitation was the sample size, which was less to arrive at a generality. Hence, our study need to be considered as a preliminary step and has to be done at a multi-center level with further duration of follow-up so as to add more evidence to the available literature. Thank you, sir.
Hello, Rahul.
Yes, sir.
It's a nice presentation, but your slides are overcrowded. Okay.
Yes.
Yeah. So this is a comment only. Just one year you have told that it's a randomized control study.
Yes, sir.
So how did you randomize it?
Sir, actually randomization was done by a recruitment method. We actually flipped the coin, actually, sir. To be fair, it was planned that we use block randomization. So A, B, by 4 ways we have.
Was the study blinded?
So it was single-blinded. The patient didn't know, but we knew.
Okay. Did you do the registration under CTRI for your trial?
No, sir. Actually, it was not done.
Why it was not done? Any ethical clearance?
So ethical clearance was taken from the RIMS ethics community, but at CTIS, I don't think I did.
Okay. Kindly the other judges can take over.
Okay, can I ask one more question? There is time.
Yes, sir.
Yes, sir.
Yeah, is in regard to radiation technique, I think radiation oncologists. So some of the patients who are treated with this thing, four field and some 3 fields, is not.
Yes, sir.
So the number of patients accruing in those either techniques, 3 field or 4 field, in both arms, they are comparable. Did you try to compare?
No, sir. Actually, we didn't try.
Actually, number of patients accrued under 3 field or 4 fields should be comparable in both arms to be more statistically significant.
Okay, sir.
That's all, I think.
Yeah, we can move to the second.
Okay.
Okay, the next one is Dr.
Thank you,
Rohan.
sir.
Next one is Dr. Rohan from B. Barwa Cancer Institute. Dr. Rohan, please proceed.
Yes, sir. Am I audible and visible, sir?
Yeah,
Yes,
you're quite audible. Yeah.
Time start.
Presenting a case, sir, usually cause for intestinal obstruction. Next slide, please. Carcinoma esophagus, as we all know, is highly prevalent in the northeast region. A fair percentage of cases present at advanced stage and require relief of dysphagia. Endoscopic stenting is an option which provides rapid relief of symptoms. However, it has potential complications like bleeding, tumor ingrowth, and stent migration. Next slide, please. 55-year-old lady presented to the OPD with complaints of dysphagia since 7 months and cough since 1 month. She had no comorbidities. History of betel chewing was present. On examination, her performance status was ECOG 2 and general and systemic examination was unremarkable. Next slide, please. On evaluation, upper GI endoscopy showed a ulceroproliferative growth involving the esophagus from 30 to 36 centimeters, GE junction at 40 centimeters. Rest of the findings were unremarkable. CECT chest and abdomen was done. It showed irregular circumferential thickening from 2.5 centimeters above the carina. Length of the segment involved was approximately 9 to 9.5 centimeters, and contact with aorta was less than 90 degrees. There was also some patchy consolidation in the right lower lobe, along with the tracheoesophageal fistula on the right side. In view of the above findings, patient underwent endoscopic stenting, and post-procedure chest X-ray was done, which showed the SEMS in position, and the patient was discharged uneventful. Next slide, please. This is the CT scan images, as you can see. It's a bulky growth, and on the right side, you can see the consolidation in the lower zones, probably due to the fistula. Next slide, please. This is the X-ray post-stenting. The SEMS is seen in position, more clearly visible on the lateral X-ray. Next slide, please. The patient again presented 2 months later with recurrent dysphagia. On evaluation, barium swallow X-ray was done and stent was not seen. Since the patient was admitted and kept NPO, repeat endoscopy was done, but the stent could not be located. Next slide, please. This is the barium X-ray, as you can see, the irregular thickening in the esophagus. The stent is not seen in position. Next slide, please. Finally, contrast X-ray of the abdomen was done, which revealed the stent in the left iliac region, possibly in the sigmoid colon. So the patient was monitored serially by X-rays, and colonoscopy was attempted but could not be done. Patient later went into intestinal obstruction. Next slide, please. So the patient was taken up for surgery immediately, and the operative findings revealed dilated small bowel loops with the stent located in the sigmoid colon. Enterotomy and removal was tried, but unsuccessfully. Finally, segmental resection and anastomosis was done, and also feeding jejunostomy was done in the same sitting to manage the dysphagia of the patient. The patient had an uneventful post-op recovery and was discharged on jejunostomy feeds. Next slide, please. So stent migration is a complication seen due to various factors. It might be technical or patient related. The meta-analysis by Law et al. Showed a high rate of success when endoscopic sutures are used to fix the stent to prevent migration. The risk of migration in previous studies are up to 55% when there is no method used to prevent migration. The standard cadence for suture fixation involves a mucosa stent mucosa sequence followed by anchor deployment and suture cinching. The sutures should be placed in adequate depth, that is ideally into the muscularis propria, so that they are less likely to migrate. And obtaining a suture depth adequately in the esophagus can be challenging due to the working angle. Next slide, please. So sutures should be placed loosely with only minimal tension on the adjacent tissue, akin to hanging of the stent. So this allows for proximal and distal accommodation with accommodation of peristalsis, and therefore it prevents local tissue ischemia and transection of the tissue, the so-called cheese wire effect, and which occurs due to over tightening. So the available literature has been unable to determine the technical factors like the brand, the size of the stent that render the patients most prone to migration after fixation. Next slide, please. Thank you.
I request judges to ask the questions before coming to the next.
Did the patient receive any cancer-directed treatment after the stenting?
No, ma'am.
Rohan.
Okay, yeah, you have presented nice, but I have one neck in my mind. For a competitive presentation, it should be a randomized trial, If not randomized, non-randomized, comparative study is desirable. Yours is a case report only. So I think ideally, it should not be allowed, for this competition presentation. I don't know how the AONEI has given a guideline. So what is your what will be your take-home message? Are you listening?
Prevention.
Can you listen?
Prevention. No. Yes, sir.
Hello, can you listen me? No.
Dr. Rahan, sir is asking you, what is your message?
What is your take-home message?
The stent migration should be prevented by making the patient, keeping the patient nil per oral after stenting, and prevent immediate mobilization. Absolute bed rest should be done, and if possible, methods of fixation should be done.
Achha, Rohan.
It is just an observation amongst your patients. So you cannot do any study, you cannot give any result. This is a problem. It is not a comparative study. That's why this lacunae is there. So it is a form of case presentation only, which is not fit for competitive presentations. Anyway.
Yeah, Rohan.
Yes, sir.
Yeah, you have told it's an unusual case, but in the same slides you have shown that there is 55% risk of migration. So how you defend your your topic, and
sir,
what may be the possible cause in your case? Pardon?
Sir, I meant unusual cause for intestinal obstruction, sir.
Okay. And what is the possible cause of migration in your case? Did you just retrospectively reviewed it?
Sir, possibly the patient might have mobilized. We instruct the patients not to sit up and move after the stenting. So maybe that would have been a cause.
Okay, thank you.
Excuse me. Do you think that the stent has been mobilized immediately after placing the stent?
Not exactly sure, sir.
You said that after 2 months, the patient presented with dysphagia. So,
yes, sir.
So 2 months was the interval. The 2 months interval was free of dysphagia, no? And she does not have any respiratory symptoms because you had placed stent because for esophageal fistula only, not for the obstruction.
Yes, sir.
I suppose. So the patient does not have any symptoms for respiratory symptoms for 2 months. Only after 2 months he or she presented with obstruction, dysphagia.
Yes, sir. So
the stent has migrated after 1 or 2 months only, no? Not immediately. As you said that immediately patient was advised not to sit after stenting.
Yes, sir. Yes, sir.
Okay, shall we move to the next presentation?
Yeah, thank you.
Dr. Persisty from B. Barwa Cancer Institute.
Good evening, sir. Am I audible?
Yes, you are audible. Yeah, you can start.
My abstract title is a prospective study to evaluate the radiological response rate in high-grade glioma patients after the adjuvant chemoradiotherapy. Next slide. So coming to the aims and objective, the primary objective of my study is to analyze the radiological response after the completion of adjuvant concurrent chemoradiation in the patients of high-grade glioma. And the secondary objective of my study is to evaluate the acute toxicities of concurrent chemoradiotherapy, as well as to do the subset analysis of the response rate with regards to the various clinical pathological factors in high-grade glioma patients. Next slide. Coming to the materials and methods, it's a hospital-based single-arm open-label study. The duration of study is 1 year, that is inclusive of both patient enrollment as well as analysis of data. The total number of the patient is 20. The period of study is 1 year. Next slide. Coming to the inclusion criteria, I have taken the patients, those are of age more than or is equals to 18 years of age, KPS more than 60, biopsy-proof high-grade glioma patients, normal laboratory investigations, and have the baseline pre-op MRI scan for the evaluation. I've excluded the patient, those who are of age less than 18 years or more than 65 years of age, KPS less than 60 or is equals to 60, biopsy, if it biopsies other than high-grade glioma, deranged laboratory investigation, if there is distant metastasis, recurrent tumor, and if the patient received the prior radiotherapy to the brain, the patient with the serious comorbidities, and if there is progression after surgery or before any adjuvant treatment. Next slide. The plan of the study, we have taken the newly diagnosed high-grade glioma patients. These patients are evaluated post-operatively by the MRI. Then they receive the adjuvant radiotherapy with concurrent temozolomide, followed by the maintenance temozolomide, and the follow-up is done at 6 months with the MRI. Next slide. Radiotherapy is given to a dose of 60 gray in 30 fraction, and it is delivered with the VMAT technique. The target volumes are contoured according to the EORTC guideline. As you can see in the figure, the GTV is the green color, the CTV is the yellow one, and the PTV is the red one. That is done in the MRI CT image registration. Next slide. Chemotherapy is given by a temozolomide concurrently to a dose of 75 milligram per meter square. In maintenance, they are given a dose of 175 milligram per meter square from day 1 to day 5. And the cycle is repeated after every 28 days. Total number of cycles that is delivered is 6. Next slide. And the follow-up is done with the MRI at 6 months after the completion of the adjuvant treatment. The MRI response is based on the Reynolds criteria, that is subclassified into the complete response, partial response, stable disease, or either progressive disease. Next slide. Coming to the baseline characteristics of the patient, as you can see, 70% of the patients are of male. The median age is taken as 50 years. More than 60% of the patients are of the grade 4, IDH1, IDH2, H3K27 mutation, and in ATRX has been done on the post-operative specimen of the tissue and the surgery. Only the 10% of the patient underwent the gross total dissection. Coming to the histology, most of the patients, 50% of the patients have GBM histology, and the RPA, 15% of the patients have very poor RPA, that is 5th and 6th. The most common site of the tumor is frontal, followed by parieto-temporal region, and the toxicities related to the temozolomide, only the 4 patients experience the toxicities, that is maculopapular rash, hepatotoxicity, and nephrotoxicity. Sorry, next slide. Coming to the result, this is the bar chart that shows the Reynolds criteria MRI response after the 6 cycles of adjuvant temozolomide. As you can see, 35% of the patients had the progressive disease and 25% of the patients had the stable disease, while the complete response and partial response is shown by the equal number of the patient, that is 20. Next slide. Coming to the subset analysis, that is by correlating the various clinical pathological factors. As you can see, the patient, those who are older than 50 years of age, has a significant poor outcome as compared to their counterparts, that is less than 50 years of age. The incidence of progressive disease is more than 50 years of the patients. Although the relationship in the gender is not significant, but the progressive disease is shown by the more number of the patient, that is of the male. And coming to the baseline performance status, the patient, those who have progressive disease, had the ECOG 3, and the poor RPA is shown by the patients those who had progressive disease. Coming to the histology, the association between the histology and the progressive disease is significant. As you can see, 70% of the patients who had progressive disease has the GBM histology. Next slide. Coming to the IDH2 mutation, the patient, those who have the progressive disease has the IDH mutant wild type, while the patient, those who have the complete response have the IDH2 mutant. This relation is also comes to be significant. Next slide. Coming to the conclusion, in this study, we have studied the response rate of adjuvant concurrent chemoradiotherapy followed by the maintenance regimen in the high-grade glioma patients. In our study, the rate of the clinical response is almost 65%. That is, complete response is 20%, partial
We have
response
1 minute left.
partial response is 20%, and the stable disease is present in 25% of the patients. Patient tolerated the adjuvant therapy well, and the adherence was good in majority of the patients. Only the 4 patients developed grade 3 and grade 4 toxicity. However, the increasing age, poor baseline general status, GBM histology, and IDH2 wild type associated with the poor outcomes. The limitation of my study is a very small sample size and a limited follow-up. Next slide. Thank you.
Judges, please question.
Hi, Prashasti. It is Dr. P.S. Roy here.
Yes, sir.
As you have done a prospective one, Prashasti, can you tell me what is the novelty of the trial? Because it has already been approved that you have to go for concurrent CTRT followed by adjuvant temozolomide in a patients with high-grade GBM. So what is the novelty in your one?
Sorry, sir.
What is the novelty of your study?
Sir, I'm just correlating it with various clinico-pathological factors, how it's going to be respond with various factors, and finding the relationship with the response rate with MRI.
Okay, in a northeastern population.
Yes, sir.
Okay.
So what is your this thing? I mean, how you comment? Your comment, good result or treatment outcome?
Yes, sir. As you can see, the 65% of the patient has shown some response. It can be clinical, stable, or partial response.
Without comparing with some other treatment, how can you say your treatment is giving better results?
Yes, sir. That I can see that it's not a randomized study, but as you can see, the patient, those are who have good general status, younger age, and those who underwent those who have IDH mutant, they respond well.
Okay.
Yeah, Prashasti, you have told that you have a smaller sample size. What would have been an adequate sample size for your study?
Sir, the
Why
p-value
you
is
have made that comment? Why you took you should have a good target samples, target, no? Then only you can achieve that. Otherwise, in the fast go, if you are just biased that you will take a smaller sample just for this is a pilot study, or there are similar type of studies as one of the judges have.
Yes, sir. Sir, actually, the time period is very less, 1 year. That's why. That includes the inclusion as well as analysis, sir.
Okay, theek hai, chalo.
So shall we move to next presentation?
Yes.
Okay. Next is Dr. Chandrasekhar Bihari from B. Barwa Cancer Institute.
Good evening, sir. Am I audible?
Yes, you are allowed to proceed.
Good afternoon to everyone. I'm Dr. Chandrasekhar Bihari, MCS trainee from Department of Surgical Oncology, B. Barwa Cancer Institute. Today, abstract of my title is pathological profile of gastric cancer patients who underwent radical gastrectomy with lymphadenectomy, the retrospective analysis in Northeast India. Next slide, please. The primary aim is to identify the pathological characteristics of gastric cancer patients from Northeast India who are undergoing the radical surgery. The secondary aim is to identify whether the surgery is upstaging the disease and to identify the margin positive rate on final HPE. Next slide, please. Study is a retrospective study conducted from January 2017 to February 2020 in the patients who underwent surgery in this period. All patients who underwent radical gastrectomy with lymphadenectomy are included. The final analysis has included only R0 resections and cases who are non-metastatic and final HPE. Next slide, please. The study variables studied include histological type, grade, location of the tumor, margin status, perineural invasion and lymphovascular invasion, depth of invasion, and stage, number of nodes isolated, whether isolated segmental tumor deposits are present or peritoneal deposits, and PNM stage. Next slide, please. Categorical variables are measured with proportional percentages. Continuous variables are measured with mean and median. IBM SPSS software version 21 was used for statistical analysis. Next slide, please. The total number of patients who underwent radical surgery for gastric cancer in this period is 101. R1 resection was identified, margin positivity in 6.9% patients. Non-contiguous omental deposits are present in 13.8% of patients. Both omental deposits and R1 resection identified in 2.9% patient and 1.9% patient at peritoneal deposits alone. There is in the final HPE, 2 patients had a large B-cell lymphoma histology, and 1 patient had a non-regional lymph node metastasis, and post-op mortality occurred in 2 patients, and which comes to 1.9%, and peritoneal deposit and margin positivity in 1 patient. Finally, the analysis, the most common site is entropyloric lesion, which included 77.2% of patients. Proximal stomach in 15.8% of patients, and mainly predominantly body of the stomach in only 7%. Next slide, please. The most common histology in our study is adenocarcinoma intestinal type, which accounted for 68.4%, and signet cell or diffuse variant identified in 26.3%, and 1 mucinous variety and 1 adenosquamous variety was identified. Around more than 50% of patients have poor grade tumor, poorly differentiated, and around 26% of patients have lymphovascular invasion, and 17.5% of patients had a perineural invasion, as tumor location is already mentioned. Next slide, please. Coming to T stage, most of the patients are presented in locally advanced stage only. T1 constitute only total 6.8%, whereas the most common stage is T3 stage, which is 42%, and T4A in 35%, and T2 comes next is 14%, and nodal N0 and final HP and 35% patients are N0 status, and N3 status is 28%, followed by N1 and N2. Most common stage at which the present was is stage 3, which includes 64.9%, and second common stage is stage 2, 28%, and stage 1 is only 5.3%. The number of nodes isolated are 20 per mean number of nodes isolated, with a minimum of 3 nodes and a maximum number of 45 nodes identified. Next slide, please. In our analysis, finally, 16 patients received neoadjuvant chemotherapy. The response was assessed with the tumor regression score. In that, out of 69 patients had a partial response, grade 2 response, whereas only 1 patient had a complete pathological response, and 2 patients had a near complete response, while 4 patients had no response, no significant response. Next slide, please. In our study, combining the R1 microscopic margin positive as well as patients in which metastatic disease along with margin positivity, the overall margin positivity rate stands at 10.8%, which is 11 patients, and non-contiguous omental deposits percentage stands at 16.8%, and 3% has 3 patients had a peritoneal disease other than omental deposits. So in our study, the surgery, after surgery, the final stage of the patients were around 1/5 of our study population was upgraded to metastatic stage. 20.7% has been upstaged to stage 4 and final histology. Next slide, please. The type of surgeries, as most common tumor is in location is in antrum. Distal radical gastrectomy is the most common surgery done, 61.4%. Multivisceral resection was done in 4 patients, out of which 3 patients are undergone splenectomy and 1 patient cholecystectomy. 98%.
1 minute left.
D2 and D2 plus only in 1 person. Next slide, please. So majority of patients who are getting operated are presenting in the locally advanced stage and with higher grade tumors. And the surgery can upstage the disease to metastatic stage in almost up to 1/5 of patient. Intraoperative frozen assessment of margins can reduce the chance of positive margins, especially the distal margin. And perioperative chemotherapy should be emphasized for downstaging the disease. Thank you, sir.
Thank you, Dr. Chandrasekhar. Now the session is open for question and answer.
What about the HER2 new status? Was it done on?
Ma'am, we in this study it was not done. But in our
Why was it not included in the profile in your HPE final HPE workup?
Routinely in a curative setting, we are not doing a HER2. In a metastatic setting, metastatic patient, we are doing for HER2 status, metastatic adenocarcinoma.
Yeah, Chandra.
Sir.
Yeah. What do you mean by radical gastrectomy here?
Gastrectomy, standard radical gastrectomy with a margin of at least 5 centimeters with lymph node dissections.
All you are resorting to D2?
Yes, sir. Only D2 patients are included, sir. Who are under D2 or D1 less than D2 are not included in this study.
What is the novelty of your study over here? Why you took up this study? Anything new you came up with?
We want to see the profile of the patients on what stage and they are presenting to us mainly, and what are the pathological characteristics that are associated in the Northeast population.
What did you find? How does it differ from the rest of the country, the patient profile over Northeast?
Sir, we have in the rest of the country compared, most of them are in advanced stage only, sir. And rest of the country also not much difference we have found. But in Eastern Asians, they have an early stage presentation because of screening programs. We don't have screening programs, so most of our patients are in advanced, locally advanced stage presentation.
In which state of the Northeast India is the highest density?
In Mizoram, sir. Aizawl is the.
Okay, thank you.
Thanks.
Okay. Shall we proceed to the next one?
Yes, yes.
Okay. Now the next one is Dr. Ashutosh from B. Barwa Cancer Institute. Dr. Ashutosh, please proceed.
Good evening, everyone. Today I am presenting a rare case report of synchronous diffuse large B-cell lymphoma and a retroperitoneal liposarcoma. My idea to present this case report is, this is a very unusual case report which has been reported. This is the first case which has been reported till date. So previous slide, sir. Coming to introduction, the synchronous occurrence of dual primary of lymphoma and sarcoma is rare, but there have been reports of this synchronous malignancy occurring in patients who are on immunosuppression. Next slide, please. So here I present a case report of a 54-year-old male who presented to us in September 2020 with a history of right-sided abdominal lump since 2 months. There was no history of any comorbidities, no history of any family history of cancer. On examination, his ECOG performance status was 1. There was no pallor icterus or generalized lymphadenopathy. On per abdominal examination, there was a approximately 13 to 20 centimeter firm to hard lump palpable over the right side of the abdomen, which had restricted mobility. The external genitalia was normal. Next slide, please. So on CT scan, it showed a large lobulated mass occupying the right side of the abdomen, where the right sided pelvic system was dilated due to the pressure effect on the right ureter and kidney. There were also few retroperitoneal lymph nodes enlarged. Next slide, please. And there was no hepatic or lung parenchymal lesions. Next slide, please. Patient underwent exploratory laparotomy and in toto excision of the mass with the removal of the enlarged retroperitoneal and right pelvic nodes was done on October 2020. Intraoperatively, it was a large growth in the retroperitoneal region extending from the subhepatic area to the pelvic rim. There were also multiple enlarged nodes in the paracable, interaortic cable, paraortic, and right common and external iliac region. There were small nodes in the small bowel mesentery. Next slide, please. So on the left side of the photograph, we can see that the large mass occupying almost a whole of the abdomen over the right side with pushed bowel loop to the left side. After removal of the mass, it weighed around 7.2 kgs. Next slide, please. The final histopathology report of the retroperitoneal mass came to be well differentiated liposarcoma with all margins free and necrosis being less than 5%. There was no lymphovascular invasion or peridural invasion. The nodal specimen showed non-Hodgkin's lymphoma. The IHC done showed it was to be diffuse large B cell type of variant. Next slide, please. Post-operatively, patient received 6 cycles of R-CHOP regimen chemotherapy, following which patient received 36 gray of involved field radiation therapy, which got completed in August 2021. After completion of the adjuvant therapy, PET CT was done in October 2021, which showed a metabolic complete response. Next slide, please. So, multiple primary neoplasms can constitute around 2 to 10% of all malignancies. Various factors have been considered to be a pathogenesis for multiple primary cancers at anatomically distinct sites. The liposarcoma and non-Hodgkin's lymphoma may be related to unidentified familial disease or spurious association may be present. Next slide, please. The multiple primary neoplasm, this poses a diagnostic and therapeutic challenge because of increased rate of complications and development of subsequent malignant neoplasms. Next slide, please. So I can conclude that retroperitoneal mass can arise from various tissues and are a diverse group, including some rare neoplasms. Coexistence of sarcoma and lymphoma in the retroperitoneal is a possibility, and it needs tailored oncological care. Thank you.
So again, this is a pure case presentation. I think students should try for comparative studies, preferably prospective randomized. Hello?
Yes, sir.
Hello? Yes, sir. So you should try for the same prospective trials in future. Yes, presentation in future. Not be
so my idea behind was this was the first case. This was the first case of the no such case has been reported.
Okay, that's all from my side.
Any other question?
So we can move to the next one.
Okay, next one is Dr. Tanshi from MMC. Dr. Tanshi Daljit.
Am I audible, sir?
Yes.
Yes, you are audible.
Good afternoon to all present here. I'm Dr. Tanshi Daljit, PG from Radiation Oncology Department, MAMC. I'll be presenting a case report on the cutaneous metastasis and bladder cancer. Next slide, please. Now, according to the Globocan 2021, bladder cancer is the 11th most common malignancy worldwide, and it is the 17th commonly encountered cancer in India. Environmental exposure is the most common factor causing it, for which smoking is the most common cause, and it commonly presents with hematuria. Bladder cancer, it often metastasizes to lymph nodes, lungs, liver, and bone. Cutaneous involvement is rare, and it is seen in only 5.3% of malignancies. 0.84 are reported in bladder cancer. Next slide, please. Coming to the case report, a 65-year-old male presented with hematuria for 1.5 years to our hospital. The CCT showed a 2 into 1.8 centimeter lesion along the bladder wall, which was along the right lateral and the posterior bladder wall. TURBT showed a high-grade urothelial carcinoma. The patient was kept on intravesical BCG installations for 6 weeks, and the patient then absconded. He presented after a year with acute onset hematuria. MRI was done, which showed a bladder wall lesion in the posterior and right atrial wall, which was of 2.3 into 2.6 centimeters, compressing the right vesico-ureteric junction, causing hydroureteronephrosis. Next slide, please. Radical cystectomy with ileal conduit was performed. HPE showed a high-grade urothelial carcinoma extending through the bladder wall with focal prostate involvement. The patient again absconded. He presented after 4 months with a forehead swelling. NCCT head showed a soft tissue swelling with intact bony tables. FNAC was consistent with metastatic urothelial carcinoma. Next slide, please. Initially, the plan was to give both cisplatin and gemcitabine, but because of the poor performance status and deranged KFT, he was started on single agent gemcitabine. PET-CT showed an FDG-enhancing lesion in the left frontal scalp and a right humeral head. Palliative radiotherapy of dose 20 grain 5 fractions was delivered to the scalp lesion, and 8 grain single fraction was given to the right humeral head. The patient expired 2 months after the radiation therapy. Next slide, please. Coming to discussion, metastatic cutaneous involvement is rare in bladder cancer, and it is due to the iatrogenic implantation, which is the most common, direct tumor invasion, hematogenous and lymphatic spread. There is no clear clinical demarcating criteria from other dermatological lesions. IHC status are variable from case to case. Synchronous expression of CK7 and CK20 are seen in 89% of the cases, so was seen in our case. Gemcitabine with cisplatin is the preferred regime. MVAC, that is methotrexate, vinblastine, doxorubicin, and cisplatin being an alternative to it for metastatic disease. Cutaneous metastasis can be considered as an ominous sign. It may be the initial sign of advanced disease, and resistance to treatment is commonly seen. Next slide, please. The table over here, it shows other 10 cases which have been reported in literature. No similar case has been reported in India. Next slide, please. Coming to conclusion, patients of bladder cancer with cutaneous manifestation should be evaluated for probability of metastasis to other sites too. Resistance to known treatment is commonly seen and is associated with poor survival. Thank you.
Okay, thank you, Dr. Tanshi. Now session is open for question and answer.
One question is there for her.
Yes, sir.
Your PET scan shows there is a lesion in the humerus.
Yes, sir.
And also in the scalp.
Yes, sir. The scalp, yes, sir.
So is that lesion was scalp from the bone or it is from the fitness?
So it's a cutaneous lesion because we'd done a CECT before and it showed that both the tables of these bone were intact. So the lesion, it was arising from the scalp only. We confirmed this thing from the radiologist also.
Okay.
So it wasn't a bony problem.
When the PET scan was done, after how many months?
So the PET scan was done after 3 cycles of giving gemcitabine.
Okay, then the disease progressed to the.
Yes, sir. It was a progressive disease. Yes, sir.
Okay.
It had progressed. The patient also presented with the bony lesion also after that, the right humeral head.
Okay, fine.
If there is no more questions, then shall we proceed to the next presentation?
Yeah, please. Yeah.
Next one is Dr. Ravindra Purohit from Vikas Cancer Institute.
Ravindra, are you there?
Good evening, respected dignitaries. Today I'm presenting a rare case report of osteoclastoma of the first rib. Next slide, please. Osteoclastoma or the giant cell tumor are locally aggressive benign neoplasm arising from epiphysis of a skeletally mature long bones. It commonly occurs in 3rd and 4th decade individuals with a slight predilection to females. Most common site is around knee joint, pelvis, humerus. GCT involving the rib is a very rare entity which has an incidence of less than 1%. A very few cases of GCT involving the first rib has been reported worldwide. Next slide, please. Here is a 17-year-old adolescent girl present with a painless swelling on the right side of the upper chest since 8 months. Patient underwent an open biopsy of the lump at a private hospital 2 months ago, which found out to be giant cell tumor. She had presented to our hospital with a severe neuralgia of upper limb, but there is no neurovascular deficit, and there are no symptoms related to distant metastasis. Next slide, please. On examination, there is a globular shaped swelling of size around 6 to 5 centimeters noted below the medial end of the clavicle. Is hard, fixed, and non-tender with smooth margins. The distal pulses, arm and finger movements, the sensation of the upper limb are normal. The biopsy scar is noted on the right side of the neck. Chest X-ray showed a radio opaque density in the right upper chest wall just below the clavicle. Next slide, please. The CT scan has been done, and the CT scan shows a tumor of size around 6 into 5.2 centimeters arising from the first rib with replacement of the whole rib, as shown in the photographs, and the lungs are normal. Next slide, please. After proper preoperative workup and counseling of the patient, we plan for a surgical resection of the tumor. We had approached it by using an anterior Dottavelli transclavicular approach was used to resect the tumor. Intraoperative, the tumor was noted involving the whole of the first rib with abutment to the surrounding structures. The whole first rib and the tumor was excised in toto, separated from the surrounding subclavian vessels and the brachial plexus. Next slide, please. As shown here, the tumor is resected completely from the adjacent surrounding structures without any damage to surrounding structures. Next slide, please. Postoperative period was uneventful. ICD was removed on day 7 and the patient was discharged on day 10. Post-op HB revealed multinucleated giant cells intermixed with spindle cell cells. Post-op X-ray shows completely excised first rib with no residual tumor. Patient is on regular follow-up. The last follow-up was 1 week ago, which is normal. Presently, there is no neuralgia, but the minimal paresthesia at the fingertip is present. Next slide, please. GCT are rare bone tumors with incidence of around 5 to 10%. It commonly affects the appendicular skeleton. Involvement of axial skeleton is very rare. GCT involving ribs is very rare entity with an overall incidence of less than 1%, and a very few cases has been reported worldwide. It is very rare to find a GCT involving both anterior and posterior part of the rib, first rib, which was seen in our case. Giant cell tumor of the bone generally occurs in a skeletally mature individuals with a peak incidence between 3rd and 4th decade of life. But incidence in a skeletally immature or a near mature is less common with incidence of around 1.6 to 8%, as in our patient who was in 17 years old, adolescent old. The treatment of GCT is either extended curettage or a surgical excision. We opted for an in-toto surgical excision as the treatment of choice. Next slide, please. To conclude, in children and adolescent, fibrous dysplasia and Ewing sarcoma are the most common neoplastic lesions of the rib. The remarkable features making our case to be rare are the site of the tumor, which is the first rib, and the age of presentation, which is to be adolescent. The tumors of the first rib can be excised safely without damage to the adjacent critical structures. Thank you. Next slide, please.
Okay, thank you, Dr. Evan. Now the session is for question and answer.
Yeah, you did not give any chemotherapy for all the patients?
No, sir, GCT, there is no role of chemotherapy, sir. We haven't started any form of chemotherapy as we have removed completely artery resection in this patient.
But this disease has very high propensity for systemic spread. After all, it's a sarcoma.
Yes, sir, giant cell tumor has there is no role of any form of chemotherapy for giant cell tumors.
This was osteoclastoma, is not?
Yes, sir, giant cell tumor, osteoclastoma.
Okay.
Okay, Revan.
Sir.
Revan, are you aware of any chemotherapy or a disease-modifying agent which causes GCT to become operable?
Yes, sir.
Are you aware of?
We can give denosumab, sir, which we can give preoperatively. This denosumab.
What is the role of? How denosumab helps in GCT?
Sir, denosumab makes the GCT hard, sir. It creates a very hard shell around the tumor, making it operable. We can advocate GCT in the case of soft tumors where the excision will be difficult to make the tumor hard.
This is not actually it makes the tumor hard. It causes it's like it produces a pseudo capsule like material. It
forms a hard shell around the tumor.
Yeah, so that you can remove the mass and
it can be excised easily.
Okay. Again, the comment which was coming from Dr. Tomcha Singh sir, that this is a case report. So yes, I can't judge.
Really, no message can be conveyed by such study.
Yes, exactly.
It's an observation only.
Yes, sir. We are not disheartening you guys, but problem is that, see, when we are going for competition, we need to have either retrospective, very good retrospective, or a prospective one.
Yes.
So,
I
by
think,
means
sir,
of
that is
judging,
not
you know,
the problem of the students or the presenters per se. We should have divided them at the, there is no point telling them personally as what I personally feel now, because they have been perfect, so they are presenting.
I do agree. I totally agree, Dr. Arup. Anyway,
yeah, Ravindra,
rectify the error next time. Actually, the whole idea was to make them have some exposure to have the presentation. And it's not like always case report cannot be presented in a way they should be presented. Means, yes, case reports are not a study, but I feel sometimes they can also be presented in a better way where there could be a point of interest which can be generated in the judges, and they'll be more interested to ask you questions. There is also a way how the case report should be presented.
Actually, there should be separate group. We shouldn't have club together. That is okay only. Case report. What we can do later on, we can divide into case report.
Yeah, because I didn't mean that case work cannot be presented. The meaning is that it should not come under the heading of competition.
Yes,
so
sir.
there can be, as Dr. Arup has highlighted, it can be under competition head, it can be under non-competition head. So in under non-competition head, so case reports are pretty well accepted. It is nice that the students are encouraged to present any form of presentation. It's good.
Yes, sir. We hope from next time we'll categorize this. So we'll proceed to the next presentation. Dr. Roma from B. Barwa Cancer Institute.
Roma?
Dr. Roma, you are unmute.
Roma, kindly unmute yourself.
Am I audible, sir?
Yeah, you are audible.
Okay, I'll start. Good evening, respected judges. The title of my study is Survival Study of Cervical Cancer Stage 4A Patients Experienced from a Cancer Center in Northeast India. The cervical cancer is the fourth most common cancer among women in the world. Out of this, 1/5 cases are, please hold, don't change the slide. 1/5 cases are contributed by India alone. Out of 1 in every 86 women in Northeast has the risk of developing cervical cancer. Unfortunately, this preventable cancer is diagnosed at an advanced stage in among as much as 60% of cases. And among these 60%, 4% are locally advanced or stage 4 disease. When I say stage 4A disease, FIGO classifies it as invasion into the bladder or rectum. That is stage 4A disease. Next slide. Next slide, please. So at the outset, I want to highlight the novelty of my study. This is the first study done in Northeast, which categorizes the prognosis of stage 4A cervical cancer in Northeast. And this will guide us in the current management practices and if there is any scope of treatment. So the primary objective of my study is to study the characteristics of patients with stage 4A cervical cancer, and secondary objective to calculate the 3-year overall and progression-free survival. Why did I take 3-year overall? Because most of the studies have shown that the 5-year overall survival rate is as low as 5%. So I I've stick my study to 3-year overall progression-free and overall survival. Next slide, please. It is a retrospective hospital-based observational study which includes all cases of cervical cancer stage 4A disease diagnosed between January 2020 to December 2021. Next slide, please. All patients presenting to our OPD which have clinical history suggestive of cervical cancer undergo clinical examination and simultaneous cervical biopsies, and they undergo imaging to look for local spread of disease and distant metastasis in form of MRI pelvis, CT whole abdomen, chest X-ray, and if there is any doubt of invasion into bladder or rectum, we take them up for cystoscopy and bronchoscopy. Once a stage 4A disease is confirmed, the cases are taken up in tumor board meeting and the intent of treatment is decided based on the performance status of the patient. So they are given either curative treatment in form of external beam radiotherapy, 50 grays, 25 fraction with concurrent chemotherapy with cisplatin or carboplatin, followed by vaginal brachytherapy, 7 grays, 3 to 4 fraction. And palliative patients are given external beam radiotherapy, 30-grade brain infections. All the patients at the very beginning are referred to palliative care OPDs when they are diagnosed with stage 4A disease. Next slide. All these patients were analyzed based on demographic profile, performance status, clinical staging, radiological staging, histological type, cystoscopy and proctoscopy findings, intent of treatment, the treatment actually received, and disease status at the end of the study. The 3-year overall survival and progression-free survival, I'm going to present the preliminary data of this of these data. Next slide, please. Next slide. Okay, please wait. The total number of patients included in the study were 26. I want to highlight that maximum number of patients belong to performance status 2, which means that they were able to carry out limited self-care, and 5 patients among 26 had a PS of performance status of 3. That means they were confined to a bed or chair more than 50% of their awake time. So this highlights the poor performance status with which the patient presents, and 77% of the patients which were included in my study had invasion of bladder, and 15% had rectal invasion, and both bladder and rectal infiltration was seen in 8% of patients. Next slide, please. So at the end of the study, it was seen that only 3 patients out of 26 patients had received curative treatment, that is external beam radiation with concurrent chemotherapy and brachytherapy. Among this, only 1 had received concurrent chemotherapy. The rest of the patient either received only palliative RT or palliative chemotherapy. 9 patients received best supportive care, and because of COVID, because of poor performance status, 7 patients did not receive any treatment at all. Next slide, please. Previous, okay. So the preliminary survival analysis at the end of the study reported that among 26 patients, 14 patients have already succumbed to the disease. That is, the overall survival at the end of study is 46.1% only. Most of the studies done till now have shown 3-year overall survival to be varying from only 19 to 25%. So at the end of 3 years, I think my study will also show similar results, but I'll wait for the results till I complete my study. So the mean survival is 8 months only. As we can see the survival curve, it shows that with time, the number of patients alive is decreasing. Most of the patients are alive. The patient I had shown had received curative concurrent chemoradiation is alive till now, and it's been already 18 months for her. Next slide. So I would like to conclude my study and my presentation by saying that I want to give everyone a take-home message. Patient with stage 4A disease have to be managed by a multidisciplinary team, which involves gynae oncologists, radiation oncologists, medical oncologists, palliative care physician, social worker, and nurses, because it is not an early disease anymore. It has advanced. It will require a constant vigilance, because patient will not only have symptoms of vesicovaginal fistula, they will have pain, they will have constant pain, their nutritional status also will be poor. So it is not work of only 2 or 3 people, it is work of the whole community and whole medical team. And since we have already known from my study and previous other many studies done by Rose et al. In 2010 and in 2019, another systemic analysis was done where they have shown that the stage 4A has dismal prognosis. So focusing on this is good, but we have to highlight this. We have to fulfill WHO's 90-70 strategy of controlling the cervical cancer and eliminating it. So we have to focus on immunizing the patient. At 90% of girls should be immunized by the age of 15 years, and 70% of the women between age of 35 and 45 should undergo a high performance.
Roma, your time is over.
Okay, sir. Thank you, sir.
Thank you, Dr. Roma. So now the question and answer session.
So in the patients you have studied, what is the median follow-up?
Pardon, sir?
What is the median follow-up of the patients you have
Median
treated?
survival till now, sir, it's
No,
8
median
months.
follow-up, median duration of follow-up.
Median duration of follow-up is 10 months only.
Okay. And further you are having, what is the response rate?
Sir, response rate, sir, most of the patients, as I have shown in my graph, that most of the patients receive only best supportive care. So none of the patients, only 3 patients out of 26 patients, that is around 10% received curative EBRT with concurrent chemotherapy. So the response rate was poor, sir.
Yeah. So your result, you have combined both the two modes of treatment, curative and palliative, is it?
Yes, sir. Yes, sir.
The combined results.
So actually in our hospital also the patients are counseled based on their performance status, based on their willingness to undergo a pelvic exentration after curative intent. So most of the patients are given palliative RT or best supportive care only.
Okay. You did not highlight on the toxicity at all. How it is? How's the toxicity profile?
Sir, because of limited time and I could not present all my results, sir.
Okay.
Dr. Roma, I'm just curious, how many received 30 gray intent fractions? How many received?
Can I go back to my slides? Sir, only 5 patients out of 26 received palliative RT, ma'am.
Okay. And did you at all analyze whether there was symptomatic relief of pelvic symptoms with any difference, whether with the curative or with the palliative fractionation and was there any difference? Symptoms?
Definitely, ma'am. The patient who received curative chemotherapy plus radiotherapy is still alive. This I wanted to highlight, ma'am. The one patient who received concurrent chemoradiation is still alive, and among 5 patients who received palliative radiotherapy, 3 have already died.
Yeah. Not the survival, but I'm just talking about the symptoms, symptom control.
The symptom relief is there, ma'am. The patient are symptomatically, those who are alive are symptomatically better, ma'am.
So my only suggestion would be like a quality of life questionnaire, if you can include. I think that would be very helpful.
Okay, ma'am. I will include. Thank you, ma'am.
Hi, Roma. It's a nice presentation.
Thank you, sir.
Yeah. So, what is the novelty of your study actually?
I highlighted in the beginning of the study, sir. This is the first study which acknowledges purely 4A cervical cancer being treated at the Northeast Cancer Center. And it will guide us what is the current practice which is being done at our hospital and if there is any scope of improvement.
Okay, what guidelines do you follow presently?
So presently, once the patient is diagnosed with stage 4A cervical cancer, based on the performance status of the patient, if there is any presence of any comorbidities, if there is any presence of hydronephrosis, and after proper counseling, the patient are divided into either curative group or palliative group. The patients with curative group are told about the toxicities and also the risk of once the patient develops a vesicovaginal fistula or vesicorectal fistula, they might need a pelvic exenterative surgery.
No, I'm just referring to which guidelines you are adopting to.
Pardon, sir. Most of the patient, as you have seen, sir, most of the patient are either given
So this
palliative
is the WHO
radiotherapy.
guidelines or recommendations by any group specially?
Sir, the 4A is included under locally advanced cervical cancer. So
Okay.
4A patients' recommendation is to give curative radiotherapy with concurrent chemotherapy, which the dose which I have highlighted earlier. But we have to cater a patient where the performance status is poor. They have more comorbidities, the higher tumor burden, and most of the patients do not give us consent for curative intent treatment, sir.
Okay.
Okay, Dr. Roma.
Yes, sir.
Dr. Roma.
Can I intervene?
Hello.
Hello, can I?
Yes,
Can I ask?
Yes, sir.
sir, go ahead.
Can I ask?
Sir, only judges are allowed to ask the question.
Okay, sorry. Okay.
Yes, sir.
Roma.
Yes, sir. Yes, sir.
From the very beginning of your presentation, I was just wondering to hear about something about quality of life. You know, those patients are having a rectal involvement, vaginal involvement. So, you have not included that part actually. So
this
you
study,
all
sir,
know
I
that
have
their
not
survival
included.
will be less.
In this study, I have not included, but this has given me an idea to do another study, sir. I have not included this. Maybe I'll include it in another study.
Okay, shall we proceed to the next presentation?
Okay.
Thank you, sir. Thank you, sir.
Next one is from Dr. Chandrasekhar Bihari from Dr. B. Barwa Cancer Institute. This is his second presentation in this current session. Dr. Bihari.
Sir, am I audible? Hello?
Yes.
Am I audible?
Yes.
Yes.
Yes, Dr. Chandrasekhar.
The abstract title was role of metastatic lymph node ratio to identify it as an independent prognostic factor in gastric cancer following curative D2 gastric resection. Next slide, please. The study design is a combined prospective as well as retrospective observational study, and inclusion study periods from January 2017 to February 2020. Inclusion criteria is all gastric cancer patients who underwent a curative R0 D2 gastrectomy are included. Exclusion criteria include patients who have died due to operative complications within 30 days post-op mortality, R+ resection, metastatic carcinoma identified in post-op HPE, or intra frozen detected liver, peritoneal, and non-regional lymph node metastasis patients are excluded. These patients are followed up for 2 years from the date of surgery. Next slide, please. The primary aim is to assess whether the metastatic lymph node ratio as an independent prognostic factor for 2-year overall survival. The secondary aim is to use metastatic lymph node ratio as a prognostic factor for identifying disease distant recurrence-free survival, and to also correlate the grade of tumor, lymphovascular invasion, perineal invasion, depth of tumor, pathological type, and location of tumor with relation with metastatic lymph node ratio. Next slide, please. The variables are depth of tumor, T-stage, number of lymph nodes isolated, whether less than 15 or more than 15, number of positive lymph nodes, TNM stage, and metastatic lymph node ratio. The dependent or outcome variables assess a 2-year overall survival and 2-year distant recurrence-free survival. Next slide, please. The statistical analysis was receiver operating characteristic curve was used to identify the best cutoff value of MLR for the threshold to identify the significance, and clinicopathological variables and survival was analyzed with Kaplan-Meier method. Statistical significance of difference between two curves is assessed with log-rank test. Univariate and multivariate analysis was conducted with Cox proportional hazard regression models. All the statistical analysis were conducted using IBM SPSS software version 21. Next slide, please. Coming to results, total 57 patients were included in the analysis. Metastatic lymph node ratio is the ratio between number of positive lymph nodes to the total number of lymph nodes harvested per specimen. So it have a range from 0 to 1. The average mean metastatic lymph node ratio in our study is 0.23 and the median is 0.09. The overall number of positive lymph nodes were 4.98 with a median number of 2 nodes positive. But out of study population, 20 patients had N0 status, and the maximum number of positive lymph nodes in a person is 37. Next patient, please. Next slide, please. This is the receiver operating characteristic curve, which was used to find the best cutoff value to identify the MLR threshold for survival significance. So on this metastatic lymph node ratio of 0.29 is found to be low, is found to be significant, which was so the study population was divided into low MLR and high MLR. Low MLR group has less than 0.29 and high MLR group has more than 0.29. Next slide, please. Coming to MLR, we in this population, the low MLR group, that is less than 0.29, has a percent 65%, and high MLR were 35%. And then at the end of 2 years, the 59.6% patients are alive and 40.4% patients are expired. This is the table showing mean MLR in the patients who are alive at the end of 2 years. It was 0.105 in alive group, and mean MLR in expired group is 0.415. So the p-value was significant. Next slide, please. This is the Kaplan-Meier survival function showing 1 year and overall survival for 2 years of entire cohort. The 1 year overall survival was 80.47% and 2 year overall survival was 59.6%. Next slide, please. Next slide, please. Based on the MLR, whether low or high, the Kaplan-Meier curve using Lagrange test has shown significant difference between the low MLR and high MLR. The low MLR group had a 2 year overall survival of 81.1%, whereas high MLR group has only 20% 2 year overall survival. The p-value was less than 0.01. Next slide, please. Based on the nodal classification from AJCC, the N0 N1 patients had a 2 year overall survival of 80%, N2 has 50%, and N3 stage has 25%. This is the curve showing the significant difference between all the 3 stages and 3 end stages. Next slide, please. And according to AJCC prognostic stage groups, the stage 1 patients, although are less in this study, have 100% 2 year overall survival, whereas the stage 2 has 69% and stage 3 has 53%. Next slide, please. On univariate analysis of all the potential prognostic factors for survival, only the metastatic lymph node ratio, AJCC nodal staging, and LVA are found to be independent prognostic factors. The hazard ratio for high MLR was 7.54, and the hazard ratio for death on N2 stage was 3.4. The hazard ratio for N3 stage was 5.79, and the presence of lymphovascular invasion has a hazard ratio of 3.43 for death. On multivariate analysis, the metastatic lymph node ratio is found to be an independent prognostic factor. A high MLR is associated with a significant hazard ratio for death of 4.85. Next slide, please.
Dr. Chandra, 1 minute left.
Distant recurrence-free survival, as with low MLR, has a 87% 2 year survival, and high MLR has a 75%, not significant. Next slide, please. The histological type, LVA status and PNA status has significant correlation with high MLR, and signet ring cell carcinoma and positive LVA status is correlated with high MLR. Next slide, please. This is a subset analysis in inadequate lymph node harvest. Both systems were found to be not significant in the less than 15 group. Next slide, please. Coming to conclusion, MLR system is an independent prognostic factor for overall survival following curative hysterectomy with G2 lymphadenectomy, and high MLR is associated with increased trend of a distant recurrence, and a signet ring cell histology and a positive LVA are associated with high MLR ratio. Thank you.
Doctor, thank you, Dr. Chandrasekhar. Now the session is open for question and answers.
Hello.
Yes, Dr.
Yeah, Chandrasekhar. Just tell me, is there any way out to reduce or to improve the MLR? Or preoperatively, can you assess the lymph node status having metastatic?
By imaging studies, CT.
Can PET help?
PET, sir, in stomach cancer, usually more than 50% are not FDG evade. Especially signet cell glucan receptor won't be there. So, PET as a nodal staging, it's not much useful in gastric cancer.
Any neoadjuvant treatment which can improve the low MLR patients? Outcomes of treatment?
Yes, sir. Neoadjuvant chemotherapy, the tumor regression score may be good response. Up to 16% of patients in the studies have shown that complete pathological response. But objective response was found in around 50% of patients in the study. So, NACT can improve the MLR status for most of the patients in locally advanced.
Okay, thank you.
Yeah, so you mentioned to assess response to NACT as one of your secondary objectives, but then you have not. I don't see any presentation on that. And then, yeah, I suppose that would have helped, seeing the subset of patients who received neoadjuvant versus those who underwent upfront surgery, and that correlated with your MLR, no?
But then I have studied many correlation, but I have only put the positive significant factors. It came negative in our study, but because the sample size is also only 57 patients, that might be a reason. A longer sample size and only around 20%, 26% received NACT in our study, because most patients present with either gastric obstruction or a recurrent anemia with recurrent blood transfusion requirement. So upfront surgery is the most followed practice here because of advanced stage.
All right, thank you.
If no questions, then shall we move to the next
Yeah, we
presentation?
better move because time is running out.
Yes, sir. The next one is Dr. Molika from Assam Medical College, Dibrugarh. Dr. Molika Tukin.
Dr. Malika, can you hear us?
Yes, sir.
Yeah. Can you say a little bit louder and start your
Dr. Molika, your
Okay,
timer
sir.
has started. Please start your presentation.
Very good evening to all. Respected judges, my topic of presentation is evaluation of androgen receptor expression and its correlation with the histological grades and ERPR HER2 status in invasive breast carcinoma of females. Next slide. Next slide, please. Next slide. Next slide, please.
It's already next.
Epidemiological studies have suggested that increased level of epidemiological studies have suggested that increased level of circulating androgens are associated with increased risks of breast cancer, primarily ER and PR positive breast cancer. AR is a member of the nuclear estrogen receptor family. This also include ER and PR. Estrogen hormone receptors are critical components of signaling pathways and plays a crucial role as transcription factor regulating the gene expression. Among the members of the steroid receptor superfamily, the role of estrogen and progesterone receptor is well established in breast cancer in predicting the prognosis and management of therapy. However, little is known about the clinical significance of androgen receptors in breast carcinogenesis. In HER2 positive breast cancer, the expression of androgen receptor was found to be positive in 50 to 60% cases. There is another subtype of breast cancer, that is triple negative breast cancer, which has highly aggressive clinical course with earlier age of onset and greater metastatic potential and poor clinical outcome. In this type of breast cancer, androgen receptor was found to be positive in 10 to 32%. Therefore, study was undertaken with the following aims and objectives, that are to identify the androgen receptor expression in invasive breast carcinoma and to correlate with the histological grades and ERPR HER2 status. Next slide. Materials and methods. This was a cross-sectional study done on the surgical specimen of breast tissue received from surgery department of department for histopathological examination in the Department of Pathology, Assam Medical College and Hospital, Dibrugarh. Patient included during the study period was 23, and inclusion criteria was all the cases of invasive breast carcinoma of females diagnosed by histomorphology in specimen of simple mastectomy and or modified radical mastectomy operation. Exclusion criteria were core needle biopsy sample, metastatic carcinoma to the breast, male breast, recurrent breast carcinoma, and presence of only in situ breast carcinoma. All the specimens were fixed in 10% buffered formalin and then gross and processed according to the standard guidelines, and slides were H&E stained and examined. For immunohistochemistry, representative area were stained for AR, ER, PR, and HER2 using standard protocol. And for interpretation, interpretation were done according to the ESCO and CAP guidelines. Next slide. This is a slide showing gross specimen of breast and H&E stain slide of invasive breast carcinoma showing IDC type. Next slide, please. This is the immunohistochemistry stain slide showing AR, PR, HER2 positive, where AR, ER, and PR are showing nuclear staining positivity, whereas HER2 is showing membrane staining positivity. Next slide. Now come to the result. In our study, 63.39% cases were having less left breast involvement, whereas 36.6% were having right breast involvement. Breast cancer in age group less than 29 years and 60 years above was found to be 0%, and 26.08% cases in age between 30 to 39 years, and 56.5% in age between 40 to 49 years, and 17.5% in age between 50 to 59 years. So breast cancer was more found in age between 4 to 49 years. Tumor size less than 2 cm found in 8.69% cases, between 2 to 5 cm in 39.13% cases, and more than 5 cm in 52.17% cases. 4.3% of breast cancer were grade 1, 30.43% were grade 2, and 65.2% were grade 3. And grading was done according to the modified Bloom Richardson criteria. Lymph node involvement in 30.40% cases was 0. 1 to 3 lymph node involvement was found in 13.0% cases, and 4 or more lymph node involvement was found in 56.52% cases. Out of 23 cases of invasive breast carcinoma, 56.52% were ER positive breast cancer, 26.08% were HER2 positive, and 34.78% were triple negative breast cancer. Androgen receptor was found positive in 21.73% of the patient. AR positivity in ER and PR positive breast cancer was found to be 13.04%, and HER2 and NEW was found to be 4.3% respectively. AR positivity in grade 1 was 0%, grade 2 was 13.04%, and grade 3 was 8.69%. Next slide. Now come to the discussion. Estrogen receptor alpha positive breast cancer accounts for 75 to 80% of breast cancer, and it determines the use of anti-estrogen or aromatase inhibitor in the adjuvant treatment. AR is also expressed in 74 to 77% of breast cancer cases. Co-expression of androgen receptor in estrogen receptor alpha positive breast cancer improved disease-free survival and overall survival significantly. AR expression appears to play a different prognostic role in estrogen receptor alpha positive and estrogen receptor alpha negative breast cancer. In estrogen receptor alpha positive breast cancer, AR was reported to predict favorable disease outcome consistently. Next slide.
Dr. Malika, your time is over.
Thank you, sir.
Can conclude.
You can conclude. That's okay.
Dr. Malika,
Anyway, it's okay. So the session is open for question answer.
Dr. Malika, okay, nice presentation. But over 1 year period at AMCH, you did only find 23 cases of lumpectomy specimen.
Sir, last year we couldn't collect much of sample due to COVID.
Okay. Okay.
Dr. Malika, so by estimating this androgen receptor expression, so what benefit you will have in the management of cells?
Mainly, sir, in predicting the prognosis as well as for in management, therapeutical treatment.
So, like in the therapeutic treatment, what change you would like to suggest apart from the conventional treatment?
So, targeted therapy.
Is it already established You have references?
No, sir. Trial is going on, sir.
Okay. So mainly on a prognosis as of now.
Yes, sir.
Okay.
Yeah, Malika, hello. It was
Yes,
nice.
Yes, sir.
Malika, you have not. Malika, you have not answered me. I asked about the novelty of your study. This is already well established that the percentage of AR in ERP are positive and HER2 negative. So, what is the novelty in your study? Dr. Malika, did you hear me?
Yes, sir.
He's referring to what is new in your study actually. What makes your study different from others?
Right.
Sir, I have got less androgen receptor expression. Other studies are more. In my studies, is less.
So, how come it is different?
Sir, in other study, the androgen receptor is found like 50 to 60%, whereas in my study, it is found 21.73%, 70%.
You can say you want to see this AR expression in your population of the patient. The patient is not is the population how they do express. Okay, this is an epidemiological study.
Yes,
okay.
sir. Yes, sir. Yes, sir.
Malika, why you have excluded the core needle biopsy group?
Sir, core needle biopsy is done in metastatic when we doubt metastasis.
No.
When we doubt malignancy, sir. So since we are taking already the invasive breast carcinoma, that's why, sir, it's already malignant.
When you suspect a carcinoma breast, first there is a triple assessment. You have a high suspicion. It is then nowadays FNAC have been taken over by core needle biopsy because obvious reasons. You being a pathologist, you know better why you need that. You need a more chunk of tissue rather than FNAC. What FNAC can do. So why you are not including core needle biopsy group?
Sir, core needle biopsy may give inadequate sample for
It is
IST, sir.
adequate enough for ERPR and heart rhythm. So why not androgen receptor can be added to that? Okay, we can move on to the others.
Okay, next one is Dr. Limpi from Assam Medical College, Dibrugarh. Dr. Limpi Kataniya.
Good evening, respected judges. My abstract title is A Case Report of Well-Differentiated Neuroendocrine Tumor. Actually, well-differentiated appendiceal neoplasm arises from neuroendocrine cells present in the tip of the appendix, it including the enterocomorphin neuroendocrine tumor, L-type neuroendocrine tumor, and tubular neuroendocrine tumor. Next slide. Aims and objective. Previous slide, please. Aim of the study is to determine the incidental finding in a routinely done appendicectomy specimen, and objective of the study is to determine the histopathological finding of appendiceal neoplasm, mainly neuroendocrine tumor, in a appendicectomy specimen. Next slide. History is a 25-year-old female presented with loss of appetite since last 6 months and pain in the right lower hypochondrium since last 1 month. The pain was gradually progressive and moderate in intensity. There was associated fever, nausea, and vomiting. On investigation, ultrasonography shows mild probe tenderness in right appendix, no well-defined collection noted, and barium meal appendix shows ileocecal junction is partially visualized and appendix is partially visualized. Small filling defect is noted. Next slide, please. Histopathology after appendicectomy, the specimen is received. Grossly, the soft tissue specimen of appendix of size 4 centimeter into 0.5 centimeter into 0.5 centimeter. External surface is smooth grayish white. Cut section shows a mass of size 0.5 centimeter into 0.5 into 0.5 centimeter is present at the tip of the appendix, and cut section of the mass is pale yellowish in color. Next slide, please. This is the first picture shows the soft tissue specimen of appendix, which is a smooth grayish white in color. Then second picture shows the cut section of appendix. It is pale yellowish mass present at the tip of the appendix. Next slide, please. On H&E stain done on scanner view shows uniform population of cells arranged in nest, acini, and ribbon pattern. On high power view shows individual cells are polygonal with round nuclei and finely stippled chromatin invade up to the deep muscular layer and serosa. This is first picture. At 4x view, we can see the acini or ribbon pattern of the tumor cells. Again, in the 40x view, we can appreciate the polygonal cells with round nuclei and finely stippled chromatin. Next slide, please. Next slide, please. Now come to conclusion. Primary appendix neoplasm is a rare pathology found in 0.5 to 1% of all appendicectomy specimen. Neuroendocrine tumor, carcinoid tumor represents more than 50% of appendix neoplasm that demonstrate no specific clinical presentation. Neuroendocrine tumor of appendix originates from the neuroendocrine cells present in the subepithelial neuroendocrine cells in the lamina propria and submucosa of the appendix wall. Majority of the appendiceal neuroendocrine tumor behavior is benign fashion. They are considered malignant because they have the potential for invasion and metastasis. Size of the primary tumor is most reliable indicator for distant metastasis. 30% of metastasis in tumor more than equal 2 centimeter, and mesoappendiceal invasion and invasion more than 3 millimeter also associated with the low survival rate. Grading system of neuroendocrine tumor of appendix, low grade G1 is less than 2 mitosis per 2 mm square and less than 3% of Ki67 index. Intermediate grade G2, 2 to 20% mitosis per 2 mm square and 3 to 20% of the Ki67 index. And high grade G3, more than 20 mitosis per 2 mm square or more than 20% Ki67 index. Treatment is simple appendicectomy is considered curative for tumor less than 1 centimeter, and right hemicolectomy is considered for tumor more than 2 centimeter or post-surgical margin or extremely mesoappendiceal invasion. Thank you, sir.
Thank you, Dr. Limpi. Dr. Limpi, one comment. You are presenting the case report, right?
Yes, sir.
So you are not supposed to raise the hypothesis generating question. Having been said that, you are not supposed to give aims and objectives of the case report. Okay, so you have already seen the case. Now, how you produce aim and objective of the study? Am I clear?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
Yes, I also was to tell that actually, no? Your findings is an incidental out of examining those patients being treated. You don't have any aim or this thing objectives. So there is a limitation of case presentation. Anyway, there are many presenting case presentation wrong.
Okay. If there is no more questions, then we can push it to the next presentation.
Yes.
Next one is from Dr. Mudassir Bashir from B. Verba Cancer Institute.
Hello. Hello.
Yes, Dr. Bashir.
Yeah. I am presenting a rare case of low-grade intramedullary osteosarcoma of right distal femur with discrepancy between imaging and pathology. Next slide, please. Next slide, please. Next slide, please. Low-grade intramedullary osteosarcoma is a rare bone tumor accounting for 1 to 2% of all osteosarcomas. Any bone may be affected, but there is strong predilection for femur and tibia. It's a challenge for every clinician to diagnose, because most of the time it is diagnosed as benign tumor and with no pathognomic radiological appearance and failed biopsies. Next slide, please. Our case was a 35-year-old female, married. She was evaluated outside with right distal thigh swelling, was slowly increasing for last 4 months. She had no history of any fever, cough, breathlessness, or pain at any other bony site. On examination, she had a swelling 8 to 7 centimeters, hard, fixed, non-tender, with a scar laterally. She had undergone a biopsy outside, which showed a desmoid fibromatosis. She was referred here. Next slide, please. We did an X-ray thigh, which showed a lytic lesion, characteristic sunburst appearance in the femur laterally. Next slide, please. MRI showed a mass at lower end of femur involving metadiaphysis with cortical as well as medullary involvement, along with extra osseous soft tissue component in the anterior, lateral, and posterior aspect. Next slide, please. But a bone scan, it was consistent with lytic lesion in the right distal femur. The rest of the skeleton was normal. CT thorax, there was no any metastatic disease. We did coaxial biopsy, which showed low-grade appendix tumor with differential diagnosis of malignant perineuroma, inflammatory myofibroblastic tumor, myxoid synovial sarcoma, and low-grade osteosarcoma. Next slide, please. She was multidisciplinary tumor board meeting was done in view of low-grade tumor. She was operated upfront, and segmental resection of bone along with soft tissue was done with endoprosthesis reconstruction, and she was discharged without any postoperative morbidity. Patient reported a follow-up with knee flexion up to 90 degrees. Next slide, please. Final biopsy was low-grade spindle cell tumor involving medullary cavity of bone, suggesting low-grade osteosarcoma. To differentiate it from any benign pathology, MDM2 was done. We showed our expression, which confirmed the presence of low-grade osteosarcoma. Next slide, please. So conclusion is usually low-grade intramedullary osteosarcoma poses a diagnostic challenge, which is often misdiagnosed for benign conditions. But here we report opposite findings, which imaging and radiological findings show high grade, but final pathology came as low-grade features. As we know, low-grade osteosarcoma is to be differentiated from high-grade because there is no benefit of chemotherapy and there is better prognosis and no benefit. So I have not found any case in literature in which there was a discrepancy with imaging showing high grade and final pathology was low grade. Next slide, please. Thank you.
Thank you, Dr. Mudashir. Now the session is open for question and answers.
In the biopsy report, the margins are all clear.
Yes, sir.
I suppose so.
Yes,
A low grade.
Yes.
Dr. Mudashir.
Yes, sir. Yes, sir.
Hello.
Yes, sir. I am not able to hear the voice properly.
This particular patient has received neoadjuvant chemotherapy?
No, sir. Because biopsy was low-grade osteosarcoma, we operated upfront.
Dr. Mudashir, I think there are two. Hello.
Yes,
I think
sir,
there
yes,
are
sir.
two simultaneous things are going on. Someone at the back of the room is also using the computer. I think it's echoing. You have to switch off the speaker of one device. Either you switch off from you. Yeah.
Yeah, that is interference.
Yes, sir.
Yeah, now
Yes,
it's
sir.
okay. Yeah, now it's okay.
Hello.
You switch off one device. You switch off one device.
Yes, sir.
Okay. So the patient was upfront operated, right? The patient underwent surgery upfront.
I am not able to hear, sir.
He is asking whether the
Yes, sir. Now I am able to hear.
he is asking whether the patient underwent surgery upfront or not.
Yes, sir. Patient went surgery upfront, sir.
So what makes its radiological picture suggestive of high-grade sarcoma? Do you have any difference between radiological pictures of high-grade versus low-grade sarcoma?
In this case, as MRI had soft tissue component, X-ray has sunburst appearance, which are all suggesting high-grade osteosarcoma. Usually, soft tissue component is a feature of high-grade osteosarcoma as well as sunburst appearance.
So sunburst appearance and soft tissue sarcoma, is those characteristics are of high-grade sarcoma? Is it so?
Yes, sir. Usually, soft tissue component as well as this Codman triangle and sunburst appearance are usually seen in high-grade sarcomas.
Is it?
Yes, sir.
Can you quote any radiological literature or any article where from you got that sentence? To comment that these features are only for high-grade osteosarcoma, not for low-grade osteosarcoma.
I don't remember the name of the study, but
say Mudasir, these are standard teaching. The Codman triangle is a very characteristic of osteosarcoma, but that doesn't mean that these are only found in high-grade osteosarcoma. These are merely a sign of osteosarcoma. That does not signify you whether it is high-grade or low-grade. Okay.
If there is no more questions, we can move to the next presentation. Next one is from Dr. Megha Nandwani from Narayana Super Specialty Hospital. Dr. Megha.
Am I audible?
Yes.
Okay. Can I start?
Yes, sure.
Okay. A very good evening to everyone. My poster is on influence of immunohistochemistry markers on survival and prognostic factors in endometrial carcinoma. Next slide, please. So as we know, the management of carcinoma endometrium is not well defined. The molecular characterization represents an attractive tool for predicting prognosis, survival, and adjuvant treatment. However, the cost of genetic testing is very high. Detection of prognostic markers like mismatch repair proteins and P53 by using immunohistochemistry, IHC, is an economical method. Next slide. So we did this study with the aims and objectives of to study the clinicopathological factors and IHC markers in carcinoma endometrium patients undergoing primary surgery in predicting A, survival outcome, and B, the prognosis. Next slide. So materials and methods used. So it was a retrospective study of 115 cases from 1st July 2013 to 31st December 2020 with a minimum follow-up of 1 year. All the histopathological slides were stained for IHC expression of MMR and P53 proteins using the Ventana benchmark XT system. The MMR staining was done for MLH1, MSH2, MSH6, and PMS2 proteins. MSI or microsatellite instability was labeled when there was loss of any one or more of these proteins. And MSS or microsatellite stable was defined when there was no loss of the above proteins. Next slide. Patients were stratified into type 1 and type 2 histopathologies. The clinicopathological factors, overall and disease-free survival were then compared on the basis of mismatch repair deficiency and P53 status after stratifying the population into two groups of MSI and MSS and P53 positive and P53 negative. Next slide. Kaplan-Meier curves were used to estimate the survival. Fisher-exact test and Pearson chi-square test were used to compare the clinicopathological variables and survival. The p-value of less than 0.05 indicated a significant statistical difference. Next slide. Next. So now the results. Total number of patients were 115 with a mean age of 58.9 years and a mean body mass index of 31.61 kg per meter square. The mean follow-up of our study population was 41.29 months, ranging from 12 to 102 months. Next slide. So this is the IHC staining of our study population. So out of the 115 patients, total of 97 patients underwent IHC staining for MMR and P53 proteins. As for 18 patients, adequate tumor tissue could not be found for IHC purposes. Again, these 97 patients were divided into two histopathologies, type 1 histopathology, that is endometrioid adenocarcinomas, and type 2 histopathology, that were papillary serous and clear cell carcinomas. So of the type 1 histopathology, so we had 79 cases. In that, MSI or microsatellite instability was seen in 21.5% cases. MSS was seen in 78.5% cases, and all the cases in the type 1 histopathology were P53 negative. For the type 2 histopathology, that is 18 cases, we had a P53 positive status for 5 patients, that is 27.8%. P53 negative for 13 patients, that was 72.2%. And all of them were microsatellite stable. Next slide, please. So now we come to the clinical pathological features of patients according to the type 1 histopathology, which was divided to the MSI and MSS groups. So we compared stage, age, grade. Next slide. Hello. Yeah. So microsatellite unstable patients have higher grade. Next slide, please. We also compared lymphovascular space invasion, myometrial invasion, and lymph node status. Please click on the next slide. Microsatellite unstable patients were more likely to show a lymphovascular space invasion and lymph node positivity. As for these factors, p-value was also significant. Next slide, please. Then we compared the overall and the recurrence-free survival between the MSS and MSI status of the type 1 histopathology group. Over here, as we can see, since the p-value was more than 0.05, the MSI status did not seem to influence the overall survival and recurrence-free survival of a study population. Next slide, please. So for type 2 histopathology, we compared the histopathological features between P53 positive and P53 negative groups. There was no significant statistical difference could be obtained, as only 5 cases in our study were P53 positive out of the 18 for type 2 histopathology. And also we were not able to correlate the overall and disease-free survival between the two groups due to less number of cases in this category. Next slide, please. So finally, to conclude, analyzing of immunohistochemistry status for evaluating the microsatellite instability in patients with type 1 endometrial adenocarcinomas is an alternative and efficient tool in predicting the prognosis for these patients. Further studies with more sample size can help us in studying the impact of MSI and P53 on overall survival and disease-free survival and for guiding the management of the same. Next slide. Thank you.
Thank you, Dr. Megha. Now the session is open for question and answers.
Yeah, Megha, hello.
Hello, yes, sir.
Yeah, what is the novelty of your study? Was the study never done before anywhere?
Sir, it has been done. In India, actually, there are less studies which are done on this MMR status. Like even the endometrium, sir, for especially high intermediate risk groups and high risk groups, still adjuvant treatment, though we recommend vaginal brachytherapy for few groups and EBRT, still they are under study. And sir, also POTEC 4A trial is being coming up to study this molecular profile of the patients with endometrial cancer. And in our population, we just want to see that what is the prevalence of MMR and does it actually affect the pathological features, and further, can it help us in guiding the adjuvant treatment or not? Because a lot of patients are there who present, who came to us at an age of 65 and all, and they're not willing for any adjuvant treatment, though it is recommended. So we thought if we do this MMR study and P53 study, so we thought maybe, we can just keep them under observation if they are negative for these markers.
Is there any similarities in your results with the other studies?
Yes, sir. So a lot of studies which I had gone through in literature, even in the Western literature, it has shown that MSI status is influencing the clinical pathological factors. But till now, I didn't come across any study which has affected the overall survival or the recurrence-free survival of the patients.
Okay, what should have been your adequate size of the sample?
So for type 2 histopathology in the literature, when I studied, the adequate sample size should be around 60. And like in the POTEC 4A trial, they have taken 500 sample size. So maybe if they take a large size, so they might be able to tell us or guide us in the overall and recurrent-free survival in these patients, whether it is going to affect or not.
Okay, chalo, nice study, good.
Thank you, sir.
Where is the place of the study?
Sir, it was done in Delhi, sir. We took all the North Indian patients. So because we get patients from Haryana, Lucknow, everywhere, UP side and all, and from Delhi, Chandigarh. So we took all that study. And
okay. The reason behind that is just sort of a part of epidemiological study also, because did you see that BMI is much more higher in this group population? That's why I'm
yes,
asking.
sir. Yes, sir.
Right?
Yes, sir.
Okay. Nice study.
Thank you, sir.
Okay, shall we move to the next presentation?
Yeah.
Next one is from Dr. Akash from Bhuyan Cancer Institute. Dr. Akash Guha. Dr. Akash.
Hello, am I audible?
Yes, you are audible.
Okay. Good evening, everyone. I would like to take this opportunity to present a rare case of leiomyosarcoma of anterior chest wall in a pediatric age group. The primary chest wall leiomyosarcoma is a rare subset for this tumor. In adults, this type of tumor is usually found in the retroperitoneum and extremities. When LMS is associated with deep destruction, it may mimic a primary bone tumor or metastasis. We present here the case of a histologically proven chest wall sarcoma and its management in a pediatric patient. Next slide, please. A 16-year-old female presented to the OPD with a swelling in the right upper anterior chest wall for 1 year. The lady had no history of pain at the local site, shortness of breath, or fever. The size of the swelling was approximately 10 by 8 centimeter and was overlying the clavicle and first 4 ribs anteriorly on the right side and fixed to the chest wall. Contrast enhanced CT scan of the thorax revealed a heterogeneously enhancing soft tissue mass 9.6 by 8 by 6.1 centimeter in right side of the chest wall with bony erosion and intrathoracic extension. Metastatic workup was completed with CT scan of abdomen and bone scan, which showed no distant spread. Our differential diagnosis was soft tissue sarcoma of chest wall, osteosarcoma, Ewing sarcoma, chondrosarcoma, or any infective etiology. Next slide, please. Here we can see the contrast enhanced computed tomography of the patient showing heterogeneous mass in the chest wall with intrathoracic extension. Next slide, please. Core biopsy was done from the lesion, which showed slender to plump spindle cells arranged in fascicles with collagen-forming stroma, suggestive of spindle cell neoplasm. Immunohistologically, the tumor stained positive for vimentin, CD99, and SMA, and negative for EMA, BCL2, CD117, desmin, and S100. The final diagnosis was confirmed to be low-grade leiomyosarcoma. Next slide, please. The patient was decided to get operated first in our multidisciplinary team meeting. Video-assisted thoracoscopy was done, and a 2 centimeter margin around the tumor was marked using cautery. Wide local excision of the tumor with resection of the medial of the clavicle and first part of first, second, and third ribs and part of the sternum on the right side was done, followed by reconstruction with a composite bone cement and proline mesh, along with the latissimus dorsi flap covering the mesh. Next slide, please. Here we can see the intraoperative photo of the patient marking the tumor and CT scan correlation. We can see the intrathoracic part of the tumor in VATS, and we have done a thoracoscopic demarcation. In the right side, you can see the specimen after dissection, the defect that was created, and reconstruction with bone cement and proline mesh and LV flap. Next slide, please. The postoperative HP report showed that we could achieve an R0 resection with adequate margin. Size of the tumor was 10 by 8.5 by 6.2 centimeter. Our diagnosis of LMS was confirmed. Left hand slide shows spindle cells arranged in fascicles. Slide in the middle shows it was vimentin positive, and right hand slide shows it was CD99 positive. Next slide, please. Patient was eligible for post-op radiotherapy in view of size, but it was decided in our multidisciplinary team to keep the patient under close observation in view of the low-grade histology and young age of the patient to prevent radiation-induced second malignancy in this patient. 3 months into the follow-up, the patient is doing fine. This case is unique in view of that the location of the tumor and age of presentation. A primary leiomyosarcoma of the chest wall in children is extremely rare. Until now, to the best of our knowledge, there were only 3 previous reports in the clinical literature describing a primary chest wall leiomyosarcoma in children. Other common tumor is extraosseous Ewing sarcoma, osteosarcoma, for which the management is completely different. Wide excision with a sufficient margin 2 to 3 centimeter is currently the curative option, as a defect was 15 by 12 centimeter and the involved resection of part of clavicle and 3 consecutive ribs. We had to do a rigid fixation to avoid flail chest and also have adequate soft tissue and skin cover. We used proline mesh and bone cement to reconstruct the chest wall and latissimus dorsi myofasciocutaneous flap to achieve this purpose. There are other ways of fixation like recon plate, titanium mesh, and where bone cement also can be used to reconstruct the ribs. We chose this method for reconstruction. Next slide, please. Treatments for leiomyosarcoma in pediatric age group are still under debate. A high-grade leiomyosarcoma is very aggressive, and preoperative chemotherapy surgery with wide resection or amputation and post-op adjuvant therapy is often performed. The most commonly used chemotherapeutic agents are doxorubicin, ifosfamide, and mesna, and radiotherapy is often given for post-operative adjuvant therapy. Low-grade leiomyosarcoma is often treated with surgery alone. Next slide, please. Thank you.
Thank you, Dr. Akash. Any questions?
Yeah, Akash, you have told you have been follow-up, your patient is in follow-up for last 3 months only, no?
Yes, sir. It is a short duration to tell the actual.
So what should have been the minimum duration for the recurrence in your case? You are expecting if there might be a recurrence, what would have been the minimum duration?
Sir, at least 2 years patient should have been followed up.
How old was your patient?
16 years.
16 years. So you are not considering radiotherapy depending on the age of the patient.
So yes, we are thinking that as it is a low-grade leiomyosarcoma and patient is 16 years of age, there is high chance of second malignancy due to radiation-induced second malignancy.
Patient underwent adjuvant chemo?
No, sir. We in our multidisciplinary team, it was decided to keep the patient under follow-up.
Okay, thank you.
Thank you, sir.
So how you assess the clarity of the surgery that there is no residual disease?
Sir, we histopathologically we confirmed that there was no disease. Margins were all negative, sir.
Now, apart from the local area, it being a sarcoma, there could be distant mets also.
Sir, we did preoperative metastatic workup with the CCT thorax, CCT thorax, abdomen, and bone scan. That is our institution protocol for any sarcoma patients to undergo the metastatic one.
Ideally, which test should be done?
Sir, ideally,
maybe preoperative. Yes, after treatment.
Sir, ideally it should be done that PET CT from base of the skull to mid-thigh.
Yeah, if the facility is there, it should be done even now also after operation. You have to be very sure that there is no local residual disease at the same time, no distant met also.
Yes, sir.
Okay, if there is no more questions, then coming to the next presentation from Dr. Arun PS from B. Barwa Cancer Institute. Dr. Arun PS.
Hello, good evening, everyone. I'm going to present a retrospective study on an early onset gastric cancer from a geographic area of high gastric cancer incidence in Northeast India. Next slide, please. So, as we all know, Northeastern region of India has a high incidence of gastric cancer, and young age gastric cancer usually they behave in an aggressive manner. Next slide, please. So our aim was to report about the clinical outcomes of gastric cancer when it has an early onset. According to us, the early onset was 40 years or less of age within the population residing in a particular geographic location. Our primary objective was to find out the survival outcomes, and secondary objective was to estimate the clinico-pathological features in this subset of population with gastric cancer. Next slide, please. So it was a retrospective observational study done in a single dedicated tertiary care cancer center, and we included patients of 40 years or less, and only those with confirmed diagnosis of gastric carcinoma who received treatment were included. The duration was from 1st Jan 2016 to 31st December 2020, that is 5 years. Next slide, please. So data was collected using a proforma having the following variables like socio-demographic characteristics, clinical signs and symptoms, staging, treatment received, follow-up period, and recurrence patterns and survival. And data was analyzed using the given software, and results were expressed in percentages, median values, and range. Next slide, please. So there were totally 79 patients in this 5 years in our study population. And what we noticed was a greater female preponderance, that is almost of a ratio of 2:1. And none of the patients in our study had any comorbid illness, or none of them had, though it is an younger age group of population, there none of them had a documented family history of cancer. And among this study population, 43% of the patients presented with the stage 4 disease, and the performance status according to ECOG is 0, 1, or 2. They all were in with a very good performance status. It is about 98% of the patients were within 0, 1, and 2, and about 51.9% of the cancers were distally located. Next slide, please. And there was linitis plastica noted in one patient. And the most common site of spread in case of metastasis is found to be a peritoneal cavity as nodules, pelvic deposits, and vomital kicking or malignant ascites in 60% of the patients. And the commonest histology, the poorly differentiated adenocarcinoma was noted in 36.7% of the patients. And signet ring carcinoma was, signet ring carcinoma was noted in 50% of the patients. Next slide, please. So as I told you, the median age was found to be 35 years and the youngest patient was 22 years old. And stage 1 and 2 diseases were noted in 21.5% of the patients, and stage 3 and 4, 78.5% of the patients had a stage 3 or 4 disease. Performance status 0 to 2 is almost 87.3%, and proximal tumors were 46% and distal tumors were 51.9%. Linitis plastica, as I told, it was found in one patient, and commonest histological subtype was a poorly differentiated adenocarcinoma in 29%, 36.7% of the patients, and signet ring carcinoma is noted in 25.3% of the patients. Next slide, please. So 36% of the patients were post neoadjuvant chemotherapy, and 64% of the patients underwent upfront surgery. And median number of positive lymph nodes were 6, although our extracted lymph nodes were between 42 up to 42. Positivity rates are up to 42. Median metastatic lymph node ratio was 0.35, and while on follow-up, the systemic recurrence was noted in 40% of the patients. And site of the systemic recurrence, or most common, was a peritoneal carcinomatosis, followed by a liver parenchymal and skeletal metastasis, and one patient had a pulmonary metastasis. So median time to recurrence was about 9.5 months after any sort of treatment. Next slide, please. So early onset gastric cancer is a subset of disease which occurs in the young adults, as I mentioned, and only about 10% of the patients with gastric cancer fall in this age range. So when we compare with the late onset gastric cancer, that is those with more than 40 years of age, what we noticed in our study, as well as the review of SEER database I have put up here, this population had a higher grade, higher percentage of signet ring type, higher chance of diffuse histology, and higher chance of metastatic disease when compared with the late onset gastric cancer. Next slide, please. And there is a higher incidence of nodal burden was noted, and since there are young population, there were fewer comorbidities, so they are being the better candidates for the treatment. So from our study, we can understand that gastric cancer in this age group has an aggressive nature of presentation with a high stage 4 cancer, that is metastatic cancer, and more than a quarter had a signet ring type, and high nodal burden in those who underwent surgery, and high incidence of systemic failure of about 40% within a short span of time, that is about 9.5 months. Next slide, please. To conclude, early onset gastric cancer in Northeast India has been associated with overall poor outcomes and why we have done this study actually, because what we recognize in our clinical practice is that this this population who are
Dr.
less
Gaurav, your time is over.
oh sorry, thank you.
Okay, thank you, Dr. Arun. Now the time is for question answer session.
Yeah, Arun, you can go with your explanation, no problem. Yeah, why you took up the study?
Actually, what we recognize in our clinical practice is that we encountered quite a good number of this subset of population less than 40 years, and we recognize that the presentation was looking different from the regular presentation from a late onset gastric carcinoma. We thought that our study in this subset of population might bring to notice that there might be a change required in the management in this subset of population, and this may give a clue to do a prospective study in this subset of population.
Why do you think that female preponderance in your study?
Female preponderance, high possibility. There are diffuse cancers are more in this group of population. So high chance of genetic alteration in the like CDH1 alteration running in this population are though there were the history of family history was not so prominent. None of the patient had a family history, but still we have to do a proper analysis of the gene analysis of this subset of population to come to a conclusion.
Yeah, almost 64% of your patient underwent upfront surgery as per your studies. So you have not considered for any neoadjuvant prior to surgery so that the outcome may be better?
So what we recognized was like among the 64%, some of the population they presented with an outlet obstruction. So in that case, we may need to go for an upfront surgery for those patients to relieve the obstruction. So, and that 64 does not indicate only the definitive surgery.
Okay.
What are other factors, like besides the gastric outlet obstruction? What are the other factors for which you have taken up for upfront surgery? Because I don't think so now. Without a neoadjuvant, beyond T3, you always should go for neoadjuvant therapy. That should be in bold letter, basically.
Yes,
so
sir.
what are the other reasons besides gastric outlet obstruction? In gastric outlet obstruction also, if this is a diffuse disease, you can go for second surgery. You can go. You just can reduce the block and go ahead for the second surgery after neoadjuvant. Systemic, it's a systemic disease too also. So you have to think about in this as per systemic therapy also, because it's a systemic disease too.
Yes, absolutely, sir. Those patients who went for GJ were found operable. Who were found to be less than. Those who required neoadjuvant, we subjected them to neoadjuvant, and we have done a second surgery for those patients.
Okay. Shall we move to the next presentation?
Yeah, sure.
Thank you,
Ramesh was asking question, I think.
Actually, have you make any comparison between the Northeast India and the rest of the India in your study?
Sir, is it to me, sir?
Yeah. For early onset of gastric cancer, have you made a comparison between the Northeast India and the rest of the India?
Sir, I have gone through the papers all over the world, sir. So, like this early onset gastric carcinoma in rest of the India, I could not encounter much of literature, sir.
Okay.
Rest of the world, they have taken different age groups, sir. So they some studies have included less than 45 years as early onset. Some studies have included 35 years as an early onset because of the presentation, sir.
Okay. Fine.
Okay, next presentation is by Dr. Aparjita from Vikas Cancer Institute. Dr. Aparjita, please proceed.
Yes, sir.
Good evening, respected judges and all the audiences. Today I am going to present a case report on primary ovarian carcinoma, a rare histology which never fails to be aggressive. Next slide, please. At the outset, I would like to say that I would like to brief with the basic classification of ovarian cancer. The ovarian cancer is divided mainly into epithelial, germ cell tumor, and sex-cord stromal tumor. Of the epithelial component, the most common variety is serous, which constitutes almost 75 to 80% of the histology. And ovarian carcinoma constitutes just only approximately 1% of the ovarian cancer. OCS, that is ovarian carcinosarcoma, is so rare in the pelvis that whenever we confront any tumor in the pelvis with histopathology report of carcinosarcoma, we tend to think that the tumor is arising from uterus itself. The ovarian carcinosarcoma has rapid progression and widespread metastasis, and the prognosis is very poor with the as compared to the serous counterpart. Today, we are reporting a case of ovarian carcinosarcoma, which was initially operated at non-oncology center and was referred to us after incomplete surgery. Next slide, please. So my patient is a 44-year-old nulliparous premenopausal female with normal BMI and no medical comorbidities, who presented to us with the history of laparotomy 1 month back, which was done at a peripheral hospital for a ovarian tumor, which was incidentally diagnosed on ultrasound when she had a complaint of pain abdomen. Next slide, please. So the primary surgery which was done at a peripheral center was subtotal hysterectomy and right oophorectomy. We could not find any operative details. The patient came to us just with a paper citing histology as malignant spindle cell neoplasm. After she presented to us, we did a slide review. And the slide review, as you can see here, the histopathology showed mitotic activity greater than 6 to 7 per 10 high power field. There was presence of mild to moderate atypia. There were fascicular pattern and with extensive palisaded necrosis. And there was presence of occasional epithelioid component. To confirm the diagnosis, we ran an immunohistochemistry, and the immunohistochemistry was done to confirm the epithelial and sarcomatoid component. For confirmation of epithelioid component, CK was done, which came out to be patchy positive, and for sarcomatous component, Vimentin came out to be focal positive. Rest of the marker like SMA, Dismin, and S100 were negative. So the patient presented to us with both the incomplete surgery and the incomplete diagnosis. As these kind of tumor like ovarian carcinosarcoma are so rare that the peripheral center have very less experience both to reach the diagnosis and to further do the complete management of such patients. So next slide, please. Before proceeding further at our center, we made the patient, we did the complete metastatic workup for the patient. On CT scan, as we can see in the picture, there was presence of a residual 6 into 3 centimeter lump in the right adnexal region, which was abutting the hysterectomy stump. And there were perilesional streakiness, and there was adhesion of the bladder to the hysterectomy stump. After reviewing through all her reports and after getting the anesthetic fitness, we took the patient for completion in staging surgery. Next slide, please. So during staging and completion surgery, the comprehensive removal of all the remnant tumor, including the remnant of the lower part of the uterus, the cervix, right ovary, left ovary, was removed. Along with it, the right pelvic peritonectomy was done, and the deposits were removed from rectosigmoid area, the bladder peritoneum. Along with this, total omentectomy was performed, and sampling was done from the bilateral pelvic and para-aortic lymph node region. And there was also some deposit on the anterior abdominal wall, which was also removed. At the end, the completion of cytoreduction score of 0 could be achieved. The final histopathology report showed the presence of typical spindle and ovoid cells, which was consistent with the metastatic deposit from the ovarian carcinoma. The greater omentum also came out to be the positive, but the lymph nodes were reactive. So the final stage assigned was stage 3C for our patient. After tumor board meeting, she was started on, prescribed 6 cycles of paclitaxel and carboplatin, and the adjuvant treatment was started on time, that is within 3 weeks of the surgery. Next slide, please. Even after proper management of the patient after in our center, when we did a response evaluation after completion of the adjuvant chemotherapy, we were surprised to find that the disease progressed just within the 1 month of the completion of the first line adjuvant chemotherapy. So we labeled her as platinum resistant disease. On imaging, on the response evaluation, when the imaging was done, it showed the presence of multiple deposit in the pelvis. As we can see in the picture, on the right side of the pelvis, there was presence of 35 into 20 mm of lesion, and even on the left side, there was presence of deposit. So the disease progressed very soon. Again, she was taken to the tumor board, and the decision was made to start her on the second line chemotherapy with liposomal doxorubicin. Next slide, please. So coming to discussion, while going through the literature, I found out that the average age of presentation is 60 to 70 years in patients of ovarian carcinosarcoma, which is quite different in my case because my patient was just 44-year-old. As the name suggests, the ovarian carcinosarcoma has both the epithelial component, sarcomatoid component. The epithelial component can be of any epithelial variety from ovary itself, like endometrioid, clear cell, serous, or squamous epithelium. And the sarcomatoid component is divided into two types. It can be either homologous, which is just native to the ovary, like stromal cancer or fibrosarcoma, or there can be presence of heterologous element which is not native to the ovary, like rhabdomyosarcoma or osteosarcoma. As the number of cases is so less that at present, currently all the ovarian carcinosarcoma is being managed on the line of epithelial ovarian cancer only. There is no well-established consensus regarding what chemotherapy is to be given. However, NCC in 2021 recommends paclitaxel and carboplatin combination as the preferred regimen. The negative factors associated with this disease is overriding sarcomatoid element more than 25%, which was the case in my case. Especially if the heterologous element is there, there is negative prognostic factor if there is higher stage, higher tumor grade, or if there is large size of the tumor, or there is any residual disease after surgery, and the presence of P53 mutation and VAGE expression.
Please be fast.
So
Please complete fast.
Yeah, next slide, please. So I would like to conclude that OCS are so rare that and the prospective data are lacking, so that these kind of case report series and observational studies can contribute to the understanding of the natural course of the disease. This case also affirms the aggressive behavior of the disease, and I would like to stress upon the fact that we need to widen our vision for the rare histologies and their timely diagnosis and appropriate management. Thank you.
Okay, thank you, Dr. Aparajita. Now the question answer session.
Yes, ma'am.
Dr. Aparajita, what about the tumor markers? Were they done?
Ma'am, yeah. Actually, it was not done in the peripheral center. We ran a tumor marker for her, and the CA125 was 60, and rest of the CA and CA 19.9 were within normal limits, ma'am.
Okay, thank you.
Any more questions? If no, then we can proceed to the next presentation because we are running short of time.
Thank you.
Okay, next presentation is by Dr. Dona from Assam Medical College, Dibrugarh.
Hello.
Dr. Dona John.
Yes, sir.
Dr. Dona, please.
Yes. Good evening, respected judges and everyone. Today I'm presenting on a case report on an interesting case of angiomyolipoma presenting with flank pain. Next slide, please. My aim is to study a rare case of angiomyolipoma presenting with flank pain. Next slide. Introduction. Angiomyolipoma is a mesenchymal tumor that belongs to the family of picoma, that is a perivascular epithelioid cell tumor. It constitutes approximately 1% of surgically removed renal tumors that occur sporadically or in patients with tuberous sclerosis. Angiomyolipomas are mostly an incidental finding in asymptomatic patients. So this is a rare case of angiomyolipoma presenting with flank pain. Next slide, please. The history of the patient. This is a 35 years old, average built woman. She presented to the surgery OPD on last November 2021 with a sudden pain over the left flank since 2 days. The pain was spasmodic in type. So the surgeon asked for ultrasound and CT scan. We can see the ultrasound finding. There's an ill-defined mass lesion measuring approximately 11 into 7 centimeter, which is noted in the splenorenal region involving the upper pole of the left kidney. And on CT scan, there's a large, highly vascular mixed density mass lesion with areas of fat density within measuring 4.9 into 6.39 into 6.89 centimeter involving the left kidney with an exophytic component. Impression is given as left renal angiomyolipoma. So further, the mass was resected and sent for histopathological examination. Next slide, please. So results and observation, histopathological findings. On gross, this, as you can see, this is a soft tissue specimen of the left kidney of size 12 into 7 centimeter. External surface appears to be smooth and grayish. And on cut section, you can see a well-circumscribed non-encapsulated mass of size 6 into 5 centimeter with a pushing border. And on the cut surface, you can see a gray-white tumor with yellow and red appearance at places. Next slide, please. These are the microscopic findings on the scanned view. So different sections were taken from the mass, which shows section from the different areas of the mass showed presence of the spindle cells, mature adipocytes, and dysmorphic thick wall blood vessels. The spindle cells appear to originate from the vessel wall that are thick and hyalinized. The picture is consistent with angiomyolipoma. Next slide, please. These are the 40x microscopic findings. As you see the first slide towards the right, this is a thickened blood vessel. And in the middle picture, these are the spindle cells, elongated cells with tapering end having a bland cytoplasm look, and the mature adipocytes, large cells with a clear rim of cytoplasm, and the nucleus towards the periphery. Next slide, please. So we'll come now a discussion. Angiomyolipomas are the distinctive neoplasm composed of variable combinations of the smooth muscle, adipose tissue, and vasculature. Although most commonly they found in the kidneys, they may also occur at extrarenal sites, including the liver, the lung, and also the retroperitoneal soft tissues. Although more than half of the cases occurs in patients without tuberous sclerosis, it is estimated that 80% of the patients with tuberous sclerosis will develop an AML. Treatment. The treatment of the renal AML is surgical and excision is usually curative. However, cases resulting in death from massive local recurrence are on record. Next slide, please. So now we'll come to the conclusion. Majority of the AML behave in a benign fashion. The primary complication is retroperitoneal hemorrhage, which can rarely be fatal. Size has been shown an important factor for hemorrhage, prompting the recommendation that the tumor more than 4 centimeters be resected to avoid this complication. Renal failure may complicate massive bilateral disease, particularly in patients with tuberous sclerosis. Invasion of the contiguous organ occurs rarely and has resulted in death. This substantiates the need of assessing the asymptomatic as well as symptomatic patient for renal mass like angiomyolipoma. Next slide, please. These are the references. Next slide. Thank you.
Okay, thank you, Dr. Dona. Now the session is open for question and answers.
Thank you, Dr. Dona, for your presentation. Only one comment, because it is a case report,
Yes,
you
sir.
should not show in your aims and objectives. Okay.
Yes, sir. Yes.
Okay.
Dr. Dona, what is the exclusivity of your case? Why? What makes it interesting? Angiomyolipoma is not so uncommon.
But like in our institute, sir, we don't get like too frequent cases, sir, on angiomyolipoma.
Depending on your institute, you don't present.
Yes, sir.
Yeah. Okay.
Shall we move to the next
Yeah,
presentation?
we can move.
Next one is from Dr. Bandana Burman. Dr. Bandana Burman, please.
Yes, sir. Good evening, everyone. My name is Dr. Bandana Burman. I'm from Assam Medical College, Dibrugarh, Department of Pathology, and today I'm here to present a case report on ampullary adenocarcinoma. Next slide, please. Okay. Coming to the introduction, ampullary carcinomas or ampulla of Vetter carcinomas are actually a rare entity, and they account about only 0.2% of all gastrointestinal tumors, and they account for about 20% of all periampullary cancers. Now, ampulla of Vetter is actually a complex anatomical region that represents the junction of the duodenal and the pancreatico-biliary type mucosa, and hence a heterogeneous group of malignancies may arise from this site. And in contrast to other periampullary malignancies, true ampullary cancers present earlier in the disease course with symptoms that are mostly of the biliary obstruction. It is often difficult to distinguish between primary ampullary cancers from other periampullary cancers preoperatively. In early stages, ampullary cancers are surgically treated similar to pancreatic cancer, mostly with Whipple's, that is a pancreaticoduodenectomy. And because of the earlier presentation, resection rates are much higher when compared to other periampullary cancers. Moreover, it tends to be better than the prognosis tends to be better than the tumors which originate from tumors, other periampullary tumors and pancreatic originating tumors. Today here I have a case in which we have a 45-year-old woman who presented to the department with pain abdomen for 2 weeks, jaundice, weakness, weight loss, and episodes of vomiting for 2 days. No history of fever, cold or cough, bladder and bowel were normal. On general examination, pallor was positive, icterus was positive, cyanosis, clubbing and edema turned out to be negative. On investigations, firstly an ultrasound was run in which a CBD calculus with sludge and intrahepatic biliary dilatation was noted, hepatomegaly was found, and a mass with back pressure changes was found, which was termed to be as cholangiocarcinoma. Then after this, a CECT abdomen was done, in which again a mass was revealed involving the distal CBD and causing back pressure changes, and that was again thought to be cholangiocarcinoma. Next slide, please. Okay. In the Department of Pathology, we received two specimens. The first specimen that we received was of a pylorus preserving pancreaticoduodenectomy specimen, which consisted of the duodenum and the head of the pancreas. The length of the duodenum was 17 centimeters, and the attached pancreas measured up to 4 into 4 into 3 centimeter. The common bile duct was cut flush, and on the cut section, we found a solid-looking tumor, grayish-white in color, measuring about 1.5 centimeter into 0.8 centimeter, present intra-ampullary within the ampullary cavity. And the distance from the medial margin of the tumor was 1 centimeter. From the posterior margin, it was 2 centimeters. And from the pancreatic neck section margin, it was 3 centimeters. The duodenal cut surface revealed mucosal folds, and there was no growth or any ulcerations in the mucosal folds. Then multiple sections were taken accordingly. Next slide, please. Okay. The second specimen that we received was of a gallbladder. It was 4 into 2 into 3 centimeter in size. The external surface was smooth grayish and white. Posterior wall was thickened, and the maximum wall thickness was about 0.8 centimeter. The mucosa was velvety without any growth or ulceration, and small bits of calculi were found. Now coming to the microscopy, here we have two figures in low power and in high power, which were taken from the tumor proper with the ampulla, and it shows tubuloglandular arrangement of the neoplastic cells. And the individual cells which line these glands were highly pleomorphic with gross chromatin, prominent nucleoli, scant cytoplasm, and mitotic figures were also noted with an intense reaction of infiltrating lymphocytes in the stroma, and the section from the gallbladder revealed chronic cholecystitis. Next slide, please. Here we have picture 4, in which we can see the individual cells that are lining the glands, and these cells are pleomorphic. They have coarse chromatin and have prominent nucleoli. Figure 5 here is a section from the pancreas, which shows tubuloglandular arrangements, and 6 and 7 are the normal areas of the duodenum and the pancreas. Next slide, please. Okay. Now coming to the final diagnosis, after total workup of the ultrasonographical and histopathological correlation, it was diagnosed as a case of ampullary adenocarcinoma infiltrating the muscle layer without involvement of the head of the pancreas. with no infiltration of the metastatic tumor cells to the lymph nodes and the CBD. All the resected margins and surfaces were free of any infiltration by the tumor cells, and therefore it was staged as ampullary carcinoma stage 3B with T3A, M3, and M0, and the gallbladder tissue that showed chronic cholecystitis. Coming to the discussion, as I have already mentioned, ampullary adenocarcinoma is a rare malignant neoplasm which arises from the ampulla of Vater, which is actually a dilated conduit resulting from the confluence of the pancreaticobiliary and the common bile duct. Histologically, ampullary adenocarcinomas are heterogeneous, and they can be classified into 5 subgroups: the intestinal subtype, the pancreaticobiliary subtype, the mucinous subtype, the poorly differentiated subtype. Ampullary adenocarcinoma is a rare disease whose prognosis and classification are not well established. Coming to the histopathology, IHC, intestinal type, they stain positive for cytokeratin 20, CDX2, mucin 2, mucin 5A, and SP100. Pancreaticobiliary type stain positive for mucin 1, CK7. Undifferentiated type stains positive for P53, CD68, SMAR CB1. And coming to the treatment, standard Whipple's procedure is usually followed, or a pylorus preserving pancreaticoduodenectomy is done. And this is usually followed by neoadjuvant chemotherapy. Next slide, please. We can come to the conclusion that, again, ampullary carcinomas are rare malignancies which arise from the ampullary complex, and they present only about 0.2% of all the gastrointestinal malignancies. The ampullary adenocarcinomas, which have the pancreaticobiliary type histology, have worse outcomes than those with intestinal histology. For local diseases or the early stage, surgical resection is usually followed by administration of adjuvant chemotherapy. Gemcitabine is usually the mainstay of treatment. And for unresectable and metastatic diseases, systemic therapy with antimetabolite and a platinum compound is usually followed. Then we have these references. Thank you.
Thank you, Dr. Banna. So now the session is for question and answer.
Dr. Vandana, I have presented a rare situation. Okay, I understand. But
yes,
how rare is the situation when you talk about the hepatobiliary tumors are concerned? You gave us the incident entire GIT. Yes, it is very rare in when you talk about entire GIT. But yes, how rare when you focus into the hepatobiliary system disease?
I'm sorry, sir. I did not read about that.
But so far, myelology concept is not that rare as we talk about hepatopancreatobiliary system is concerned. Okay.
Yes, sir.
So we do often found ampullary of Vater carcinoma.
Yes, sir.
Especially when you are sitting in a cancer center. Okay.
Yes, sir.
If no more questions, shall we move to the next presentation? Next presentation is from by Dr. Apurva from Dr. B. Barwa Cancer Institute. Dr. Apurva, please. Dr. Apurva.
Yes, sir.
Okay, you can proceed.
Yes, sir. Say, am I audible and seen?
Yes.
Yeah, okay. Good evening, respected judges. I, Apurva Tap, would provide an insight into the management of vulvar Paget's disease, a recurring menace. Next, please. Next slide, please. Yeah, so it was back in 1874 when James Paget first described the disease, and it was only in 1889 when Crocker first described its extra memory variant. Accounting for less than 2% of vulvar neoplasias, it's a very rare disease to present, and henceforth we bring you these 2 case reports wherein we manage the disease with the Mohs micrographic surgery. Next, please. Next, please. Yeah. So what is most dismal about Paget's disease is the fact that it has a very high recurrence rate, amounting to as high as 60%. And that is because of its typical microscopic expansion way beyond the clinically apparent borders. Next, please. So this highlights the importance of performing a Mohs micrographic surgery which helps us to critically and thoroughly evaluate the intraoperative microscopic margins, tissue margins, so as to achieve a tumor-free margin. Next, please. So this was the first case, a known case of Paget's disease who got operated outside 2 years back, wherein a vulvectomy was performed and the margins were positive for tumor. And in spite of the fact that she would explain that re-excision is the management of choice, she went in for a follow-up, and then she came to us 2 years later with a recurrence, and it was so huge that we had to perform a Mohs micrographic surgery and lotus flap reconstruction for her in the very same setting. Next, please. And like before performing management for Paget's disease, it is very important to carry out these bundle of investigations because we need to rule out the secondary Paget's disease, and henceforth we went in with these investigations. Next, please. So coming to the intricacies of the surgeries we performed, the first step in Mohs micrographic surgery is that we delineated the vulvar lesion that we needed to excise. Then a vulvectomy was performed. And then coming to the heart of the surgery, that is the excised tissue along with the Mohs map, which involves proper marking of the tissue margins, was then sent for frozen tissue processing. Next, please. Now, frozen tissue sectioning in this particular surgery is the part and parcel of this surgery, wherein with the cryostat, the sections, horizontal sections are made, which are 5 to 7 micron thick, and they are aligned such that the skin and the deep margins, they all lie in the same horizontal plane, so as to ensure that they are all tumor-free. Next, please. Next, please. So yes, so this is a cryotome which is being shown, and we needed to perform the re-excision at least thrice before we could achieve negative margin. So this is what is Mohs micrographic surgery, wherein in stages we remove the tumor so as to ensure tumor-free margins. And then we performed in the very same setting. This is again the benefit of the Mohs micrographic surgery, that it allows us for the reconstruction in the very same setting. Next, please. Next, please. Yeah, next, please. Next. Next. So these are all pictures which are describing. Next, please. This is the entire armamentarium of what we did. Next, please. Next, please. Yeah, so this was the defect which we had, and this was the flap reconstruction which we did. Next, please. Yeah, so the second case which I want to highlight, this was a case which we managed upfront, performed a Mohs surgery for her, and she's been on follow-up with us for the last 4 years, and she's recurrence-free. So here in left, center, and right, I want to stress the importance of carrying out a Mohs micrographic surgery. Next, please. Yeah, so it's very important, the IHC markers, because vulvar Paget's disease mimics many skin lesions, and at the same time, it is of grave importance to differentiate between the primary and the secondary variants. And this is the bundle of investigation, the IHC markers, which lead us to the same. The gross cystic disease fluid protein is positive in 90% of the primary disease. And though there are many markers, but then these are the ones which are very specific. CK20 is quite specific for the secondary disease. And these are CDX2 plus for the anorectal malignancies and the uroplakin-3 for the urothelial malignancies as primary. Next, please. So being a superficial spreading lesion, there have been many retrospective studies which have totally re-emphasized on the role of achieving a negative margin, which I have shown in my 2 cases. When it was not achieved, what was the result, and when it was achieved, what was the result. Next, please. Next, please. Next, please. So yes, this was a recent study by Chang et al., which is published in the BMJ. This comes from the University of Boston, wherein they have revealed a novel approach of this Mohs micrographic surgery. They say it is a central and peripheral modification, wherein with this technique, the peripheral margin of the disease is defined using a Mohs micrographic surgery, and the central tumor-bearing island is excised at the level of subcutaneous tissue. So then this helps us to save time also during the surgery. Next, please. So the learning points that we have gathered here are that vulvar pruritus is not to be missed. and there has to be a histopath diagnosis which has to be made, because like in our second case, she had been chronically treated with topical steroids and it was quite late when a biopsy was performed for her. Second thing which I want to emphasize, because the associated malignancies are as high as 25% in extramemory Paget's disease, we need to carry out the armamentarium of investigations to rule out any sort of primary. And third, next please, that because the 5-year survival is quite high, but it is a recurring disease at the same time, so we need to keep the patients on a very close follow-up. And at the end, I want to emphasize the fact that owing to the lower recurrence rates, the high salvage rates, and the critical tissue conservation that the micrographic surgery helps us to achieve, it is a better alternative way ahead in vulvar Paget's disease management. And it should replace any sort of excisions that are going there, here, and elsewhere, which lead to a highly recurrent disorder. Next, please. Next, please.
Okay, thank you, Dr. Apurva. Now the question answer session.
Thank you.
Dr. Apurva, did you do this thing HPV status analysis before the treatment surgery?
So we had no, sir, we did not go in for a HPV analysis because we had histopathologically, in the first case, it was a case of recurrent Paget's disease, which we had histopathologically as well as with the use of IHC markers had proved. And so was the case with our second one, which revealed that it was a Paget's disease. We had proved it with the histopath markers.
So you feel it's not needed?
No, sir. So we need to rule out Paget's disease is all the more linked there with the Wilkinson classification. We have two kinds of Paget's disease, the primary and the secondary variant. The primary variant is thought to arise from the intraepithelial appendages of the epidermis. And so the secondary variant would have adenocarcinomas elsewhere, the colorectal, colon, breast, urothelial malignancy. So we carried out the entire panel of IHC markers, along with it, the all investigations to carefully locate the primary and then deal with the disease. So HPV is not linked with its pathogenesis.
Okay, with a high chance of recurrence after surgery, so what recommendation you make in the subsequent follow-ups?
Yes, sir, definitely. With so many retrospective surgeries that have been done, they have definitely said that most micrographic surgery helps us achieve recurrence-free intervals, which we have also seen in both our cases, comparing with the one which we underwent a primary upfront Mohs surgery, and the second one which we performed for the recurrent disease, wherein a local excision was performed and she recurred 2 years later. So definitely Mohs micrographic surgery is the way, and then it requires a lot of expertise of frozen section analysis, which has to be done properly. With the so I do recommend that this should be the way ahead, rather than treating them with excisions which lead to so much recurrence, so much morbidity, because these patients are generally quite old and we cannot keep on re-excising and exposing them to very radical surgeries all the time.
In subsequent follow-ups, any special
Yes, sir. Yes, sir. In spite of the fact that we carry a Mohs micrographic surgery, because of the high recurrence rate to the tune of 60%, we need to carry follow-up for these patients very precisely. So for as long as 2 years, they are followed up every 3 monthly, and thereafter every 6 monthly. So the follow-up is quite vigorous in these cases as compared to other malignancies.
Okay.
Thank you, sir.
Dr. Apurva?
Yes, sir.
Usually Paget's disease of the breast is associated with underlying invasive carcinoma.
Yes, sir.
So is it the same with this? Is there an association with an underlying invasive carcinoma in Paget's disease of the vulva?
Yes, sir. Yes, sir. Definitely. We have the invasive variant also. And before performing, there are different kind of... Hello? Yes, sir. So there is an invasive variant of Paget's disease as well. And it has been seen that when it is an invasive variant, wherein it invades, the stromal invasion is there, the basement membrane is breached, there are higher chances of lymph node involvement as well as distant mets at the same time. But then these cases are a bit rarer because mostly it is a superficial spreading lesion, but definitely we have these invasive variants also, and then they are subsequently subjected to adjuvant treatments after surgery.
Thank you.
Thank you, sir.
Okay, shall we move to the next one?
Yeah, please.
Okay, before coming to the next one, one important announcement. Judges, please note 19 number and 21 number. 19 number, Dr. Hima Bora, and 21 number, Dr. Chandrasekhar Vihari. These two are not going to present because of unavoidable reason. Dr. Chandrasekhar Vihari's this presentation was third presentation. So now next one is the last one by Dr. Dhiru Talukdar.
Sir, am I audible? Sir, am I audible?
Yes.
Yeah, it's audible.
Okay. Good evening, judges and panelists. Today I am going to present my study entitled as the standard dose versus high dose radiotherapy with weekly concurrent chemotherapy in carcinoma esophagus, a prospective randomized study. Next page. So my primary objective was to compare the clinical and radiological response rate of carcinoma esophagus among patients receiving 63 gray radiation versus standard dose, that is 50.4 gray, along with weekly concurrent chemotherapy by injection paclitaxel and injection carboplatin. The secondary objective was to compare the toxicity between the two arms. Next page. Materials and methods. It is an open label randomized prospective study. Details mentioned in the study flowchart with a 96 number of patients. 2 patients from the arm A defaulted as they didn't turn up during the time of follow-up. So 94 patients with 46 patients in arm A and 48 patients in arm B were available for evaluation and response assessment. The duration of the study was 10 months, which was done at the Department of Radiation Oncology, Bhuyan Cancer Institute, which include the patient inquiry and data analysis. Next page. So here, shown the flow chart where patient selection was done with depending on the inclusion and exclusion criteria, and the randomization was done in 1:1 basis by a computer generated platform to arm A, where 50.4 gray in 28 fraction radiation was delivered and 63 gray in 35 fraction radiation was delivered along with concurrent chemotherapy. Those patients who completed the treatment were further followed up, and those patients who didn't complete the treatment were continued as per hospital protocol. Treatment was continued. Next page. Those patients having a histology of squamous cell carcinoma, having stage of 1 to 3, non-metastatic, age between 18 to 70 years, with KPS of more than 70, with all blood parameters normal, were included in the study. If the patient refuses for further treatment or stage 4 disease involving the Z junction or KPS less than 70, with history of prior concurrent other malignancy or irradiation or chemotherapy, presence of any TOF or metastatic disease were excluded from the study. Next page. So radiotherapy details. 6 MV photon of energy was used with 3D CRT technique in both phase 1 and phase 2. The GTV primary and the GTV node was controlled based on the simulation scan, and which depending on the diagnostic CT scan or the PET scan, whichever is available, along with the UGI report for craniocaudal extent of the disease and the local extension and the nodal staging of the disease. So CTV then controlled 4 centimeter margin craniocaudally along with the circumferential margin of 1.5 centimeter to the GTV. PTV was controlled by 0.5 centimeter margin to the CTV. OARs like left and right lung, heart, spinal cord, liver, all are controlled based on the RTOG guideline. In phase 1, in both the arms, arm A and arm B, the PTV received the dose of 39.6 gray in 22 fractions at 1.8 gray per fraction, 5 days in a week. In phase 2, in both the arms, the PTV included the primary tumor along with the involved nodes with 2 to 3 centimeter craniocaudal margins. In arm A, it received in phase 2 10.8 gray in 6 fraction, and phase 2 in arm B received 23.4 gray 13 fraction. So total of 50.4 gray in 28 fraction in the standard dose arm and 63 gray in 35 fraction in the arm B that was prescribed to the PTV. Next page. So injection paclitaxel to a total dose of 50 milligram per meter square body surface area plus injection carboplatin at AUC2 intravenously weekly for total of 5 cycles was given as dose of chemotherapy. So weekly review was done to see the general condition and the clinical examination and the toxicity grading of the patient. Then follow-up was done at 6 weeks and 3 months intervals. The follow-up included the clinical examination, radiological and endoscopic evaluation. So CT scan at the 3 months was evaluated with pre-treatment CT scan, which was compared for local control of the disease with response response by RECIST criteria, that is 1.1. Next page. The results are shown in the bar diagram as follows. Most of the cases are male in gender, and most of the cases having age of more than 50 years with median age of 54.4 years of age, and having histology of moderately differentiated squamous cell carcinoma in most of the cases in both the arms, followed by poorly differentiated squamous cell carcinoma, followed by well differentiated squamous cell carcinoma in both the arms. Next page. Next page. The location of the disease was mostly mid-thoracic esophagus, followed by upper thoracic esophagus, followed by lower thoracic, and then cervical esophagus. The staging was mostly stage 2B, that is T3 and 0 disease in both the arms, followed by stage 3, that is T3 and 1, and followed by stage 3, that is T3 and 2 disease in both the arms. Length of the disease was mostly less than 8 cm in length in both the arms, as shown in the bar diagram. Next page. This is the subjective response of dysphagia, which was calculated at the time of conclusion 6 weeks and 3 months. Baseline was also evaluated. So it in the bar diagram, it has been shown that at the time of conclusion and at 3 months, there was no significant difference of statistical difference between the two arms in the grading of dysphagia. But at 6 weeks, p-value was 0.0037. That was significant, which was 85.4% in the arm B, that is grade 1 dysphagia, which is 50% in arm A. Next page. So objective response was evaluated by endoscopic evaluation for residual disease is present or not, with 84% in the arm A and 75% in arm B, which showed that there is superior tumor control in the endoscopic response in the arm A compared to the arm B, with a p-value of 0.001, which showed which is statistically significant. Next page. So objective response by radiological investigation of CT scan of thorax compared to the previous pre-RT CT scan, which showed that the response.
Dr. Talukdar, your time is over.
Dr. Dhiru, can you please complete it first?
So next page. Coming to the toxicity, anemia, neutropenia, vomiting, and the dermatitis was evaluated. Mostly patients having dermatitis grade 1, and anemia was mostly patients having mild anemia, and neutropenia and vomiting was absent in most of the patients. Next page. So coming to discussion, the subjective relief of the dysphagia and the radiological response of 3 months follow-up period by RECIST criteria was not statistically significant between the arm and A and B. But the endoscopic response showed significant difference with superior tumor control in arm A. As per CTCA criteria, the common toxicity were anemia, neutropenia, dermatitis, but no significant difference of toxicity found between the two arms. Odynophagia, diarrhea, aspiration, and pneumonitis were absent. Next page. So considering all the factors, standard dose radiotherapy, that is 50.4 gray, along with the concurrent chemotherapy, is the standard definitive treatment of locally advanced unresectable esophageal carcinoma patients of Northeast India. However, a longer follow-up of the 4 patients of our patients is required to observe to see the further trend of the study that translates into results of long-term local control, progression-free survival, or the overall survival. Thank you.
Thank you, Dr. Dhiru. Now the question and answer session.
Okay, Dr. Dhiru, thank you for presenting a comparative study after a long time.
Thank you.
So it's a really very nice study that you have done, mostly completed and ideal in most of the settings. So I just wanted to ask you one thing, post-radiation result assessment.
Yes,
What is the ideal time for assessment?
Post-radiation results assessment?
Yes, result assessment.
It is a
Early, yes, post-radiation, yes, assessment, result assessment. Okay.
So first follow-up, sir, it should be ideally done at 3 months, followed by 3 months interval for next 2 years, followed by 6-month interval for another 2 years, then followed by yearly follow-up.
And what investigations you like to utilize, for this result assessment?
Depending on the clinical evaluation, sir, I will like to do this endoscopic evaluation and the clinical dysphagia relief or not, then CT scan of the thorax, and depending on the patient symptoms.
Mm-hmm. What about PET scan, PET CT?
PET scan, normally, sir, gold standard of diagnosis is endoscopic ultrasound, but PET scans are there is a lot of logistic issues, sir. So that's why if available, then
Availability is an issue. No, ideal setting where I'm asking about, in an ideal setting where you have everything.
Yes,
so
sir.
Ideally, how will go about?
Sir, in ideal situation, I will try to, if affordable for the patients, I will try to go by PET scan, because if it detects subclinical metastatic patients to 15%, sir.
Mm-hmm. Chemotherapy you have been giving to the patients. What timing you give this chemotherapy? I mean, in relation to radiation treatment. You're giving weekly chemotherapy. What timing of the day, you're giving this chemotherapy with the time compared to radiation timing? How you assess that?
Sir, chemotherapy ideally should be given before the patient goes for radiotherapy, sir.
Okay. Preferably, how many hours before?
Pardon, sir, I don't have that.
Okay.
Yes,
anyway, congratulations, you have done a very good job.
Yes, sir. Thank you, sir.
Others, yes, your opinion, please.
Yes, Dr. Talukdar.
Yes,
Yes,
sir.
can you hear me?
Yes, ma'am.
Yes, so I'm just a little confused. In your flow chart, you've mentioned, so these patients at the beginning itself in your MDT, they were classified as inoperable or unresectable, and then is that how you kind of recruited your patients? Because I saw a lot of T3 and 0 also included. So was there a clause in your study saying that if they were reassessed and found resectable, they would go into a surgery arm, or when did you make the decision to go just for radical chemoradiation and not consider surgery even for the more sort of early stage tumors? Where in your flow chart is that in your recruitment, before the recruitment, before you in the MDT level itself, or after you, when was the decision made?
Ma'am, after tumor board decision, because of unresectability or the general condition of the patients, locally advanced disease or those metastatic disease, all those are excluded. But those patients with locally advanced, those which are not suitable for surgeries or the general condition is not that much good, those patients were included in the study after the tumor board decision was made, depending on all those criteria.
Okay, so this was upfront itself before you upfront itself in the initial MDT, the decision has been made.
After.
Okay, okay.
Yeah, do you know what prompted you to take up this study?
Because, sir, if we see the database of Northeast India, that depending on the standard, those trials are mostly of the Western or Chinese trials, those showing that the dose of radiotherapy or the dose escalation, whether as per NCC guideline, it was given that 50.4 is the standard dose. So on the Northeast people, the data was lacking, sir. So that's why I have taken up this study for whether dose escalation or the toxicity, by comparing the dose escalation and the toxicity, whether it's feasible or not to escalate the dose up to 63 gray in Northeastern people.
Do you think that physical build of the people of the Northeast is better than that of the Western population who can resist?
No, sir, because Most of the cases in our Northeast India, those esophagus cases, those are malnourished, or as I have shown in the study, those are of anemia, having mild anemia, most of the cases, because they come at advanced stage, most of the cases. So that's why the build is not that much good, that the early stage is not that much detectable at this area because of the compliance or loss of constants.
So the morbidity profile of the higher dose is more what you have seen than that of the standard one?
Yes, sir. But the study had a less follow-up, that is only for 3 months. Depending on the clinical response, other evaluation.
Yeah, I would differ. See, locally advanced is not a contraindication for surgery. There is something called salvage surgery, and surgery is the it is the curative modality. So once you jump into neoadjuvant chemotherapy full dose, if you go to 53, 63 or something like that, then it's become very difficult in the operative field. So you should have a discussion with the surgeon prior initiating the neoadjuvant radiotherapy. So when you decide to go beyond 50, then you should definitely have a discussion with the surgeon. And if
we have gone for MDT.
Sorry?
They have gone for MDT. In the MDT only it was decided.
Okay, no, I'm telling the thumb rule. Why, when you should stop, when you should consult, like in a surgery, in the center, like I'm in a periphery. Okay, so so I am talking in my context. This is the thumb rule. If you go beyond 50 gray, then the surgical it is difficult. Surgery becomes difficult. But there has not been much changes or much difficulty between 40 to 50 gray. This is what Tata Memorial study shows. But when it goes to 60, it is a hard drop stuff and it's very difficult to. So locally advanced is not a contraindication for surgery at all. But okay, your point is right. But they are cachectic. Most of them comes cachectic. But there is something called we can build up. Nutrition build up is the scheme is that very good. Their nutritional advances has come at a big way, and we can really build up people first. My point is we should always try to go for surgery if all provided well, or if everything is fine in that way. Otherwise, RT is fine. RT is the factor in the local recurrence and overall survival, definitely.
Yes.
I think we have a session tomorrow on esophageal cancer where we can discuss it more. Any other question from the judges?
No, it's a nice presentation, Dhiro.
Thank you, sir.
Thank you, sir.
Thank you, Dr. Dhiro.
Thank you, sir.
Now, any questions from judges? If no, then I would like to thank all the participants for their active participation. I would like to thank all judges for their giving the very valuable time and the patience, and all the participants. I would like to thank. Now, we can conclude the poster presentation session today, and there is a scientific session tomorrow. Will start at 4 p.m.